I'm Jeannine Rivet, Chair of the Health Policy and Management Executive Council at the Harvard School of Public Health, and my day job is Executive Vice President at UnitedHealth Group. First, I would like to thank Tom Scully and Alston for hosting this symposium, which is going to be fabulous. On behalf of the rest of the council members, most of whom are here today, we are delighted to team up with Tom again, as we did 4 years ago. The council and Alston did a symposium 4 years ago. Some of you may have been here, and it was very well received. It was pretty exciting to listen to panelists and multiple opinions about what was going to happen coming up with the elections. We'll do that again today. And it was hard for me to believe. This morning I was watching the news as I was getting ready to come over here, and the elections are like 45 days away. I keep thinking that they're coming, but that seemed to put it in better perspective. It's like soon. So this is really timely. Before we turn the program over, let me say a few words about the Harvard School of Public Health and the Department of Health Policy and Management. In the words of the Dean of the Public Health Department and School, Julio Frank, the product of Harvard School of Public Health is knowledge. Knowledge which can be put to use by practitioners, policymakers, and the public to improve health on a population basis. Give you some examples. Members of its faculty play a critical role in health policy, which is this group's focus, providing the knowledge that leads to more judicious decision-making. Some of the faculty, here are examples. Kate Baker is a member of the Medicare Payment Advisory Commission, and Nancy Kane, another faculty member of the department, formerly served in that role. Other faculty in the department, such as Meredith Rosenthal, have taught us much about payment reform and policy. Ashish Jha on information technology. Atul Gawande, who many of you may know, he's a prolific writer and a wonderful writer, along with Lucian Leap, focused on patient safety, and Arnie Epstein about quality of care and disparities. Broadly speaking, the department is dedicated to work on compelling and important problems, from making the delivery of care safer and more efficient, to expanding health insurance coverage, eliminating disparities, designing and improving the performance of healthcare systems, and many other policy areas. Arnie Epstein, who is our chair of the department, will moderate the first panel. I will introduce him later. And Bob Blendon will also be introduced later, is a senior faculty member and will be presenting today's final session. So as you can see from the agenda, which is at your seats, and some of you may have received it in advance, we have two panels. And the reason we were delayed starting was we were still waiting for panelists. So I'm hoping as I go through the introductions that they will be here. Otherwise, we'll start because we know your time is precious and we appreciate you spending your time with us this morning. The panels, the first panel will have more of a policy focus, and the second panel will have a slightly more political bent, as you can tell by the people on the panels. Our hope is to get beyond some of the political rhetoric and hear what they really think can happen on healthcare and where we fit in either as a school or our respective businesses, focusing on moving to transform the healthcare system to be more affordable, accessible, without compromising quality, and making it simpler for us to navigate. So now I'm pleased to invite Tom Scully to join me to provide his welcoming remarks and insights on the process. Tom is senior counsel at Alston Bird's this office, Washington, D.C. office, and a senior advisor at Welsh, Carson, Anderson, Stowe, the largest private equity investor in healthcare. And prior to that, important, some of you may know his name from there, was the administrator for the Centers of Medicare and Medicaid Services, and also president and CEO of Federation of American Hospitals and Health Systems. Tom.
I have no insights, actually.
What's that?
I have no insights.
No insights. No one in this room believes that.
And I'm really disappointed that I can't be on the panel to heckle Chris Jennings again, but I have chances to do that on a regular basis anyway. No, I really just want to come and thank the people. A lot of us go to many of these, and I do a number of these. And when you look at the people we have showing up this morning, it's pretty amazing, because I think we actually have one person we invited who couldn't do it. That was Paul Ryan. I know you'll be shocked to hear that. I think we invited him about 2 days before he became the VP. So, but when you look down this list from Chris, who I like to tease, we're old friends, to Joe Antos and Alan and Gail in the first panel, I mean, there's nobody in Washington that's smarter and better and knows these issues better than these guys do. So, we're flattered that they took their time. Everybody's busy to do this, and I'm personally very appreciative of that. And on the second panel, Julie Robner, who I just saw walked in from NPR, who's probably been the fairest, nicest, I shouldn't say that, she'll think that I'm sucking up to her, but yeah, fairest, nicest healthcare journalist in Washington, probably the last 20-some years that I've dealt with her. I'm sure you all hear on NPR. I think she was supposed to cover some corruption hearing this morning. She thought this would be more fun. We'll see. But, the fact that Julie took a big chunk of her day out to do this, and, Tom Daschle, who was my partner here, who I've known for years, is the nicest human being in the world in the back. Sadly got a better offer a few years ago, went to another law firm, but he's a smart capitalist. Governor Engler is coming, and Senator Lincoln, and Billy Tosnian. I mean, these are people who have lived this stuff for many years, and I think in Washington you're never going to get more smart, candid people who are going to show up on the political side and talk about these things. So we're very grateful for all of them for making the effort. Tom Daschle joined the Harvard School of Public Health's advisory board with me a couple of years ago. It's been fun to have him on there. I think I've been on there for 6 or 7 years. I can't remember. Arnie probably remembers, because it's been painful for him every minute, hasn't it? But anyway, we did do this 4 years ago. It was great fun. A lot of these people, a lot of the folks on these panels participated 4 years ago. And obviously we have a long way to go. So anyway, I hope everybody in the audience has paid your taxes so you can be counted among the important 53% that are on the right. There's no press here, I hope. Oh, Julie Robner, oh my God. But anyway, thank you very much for coming, and I'm sure it'll be a very interesting day. And a lot of this, we have our entire board here, and the goal here is to be interactive, so I hope people will not be shy. I see Gary Jacobs is here, so I know there's one guy that definitely won't be shy. But please, mix it up with these folks, and it's a small group, and we hope you'll dive in and exchange with all of our panels as much as you can. So thank you very much for coming.
Thanks, Tom. Now we will move to our panel discussion. I'm going to introduce Arnie Epstein, who is going to moderate and facilitate this panel. So Arnie is the John H. Foster Professor of Health Policy and Management, as well as Chair of the Department of Health Policy and Management at the Harvard School of Public Health. How do you say that? That's a long title. That's pretty hard to get out there. He's phenomenal. He serves as Associate Editor of Health Policy at the New England Journal of Medicine. His research interests focus on access and quality of care, especially for disadvantaged populations. He also still practices and keeps his practice as a physician. Arnie and I have known each other for several years. I too have been on the board for quite a few years, and as chair, I've had the pleasure of working closely with him on focusing on strategy, future direction, enhancing his faculty, what the research is, and then helping organize this day. So I hope that you enjoy the day, and I invite Arnie to come up and kick off the first panel.
And let me invite the first panelists to join atop. 1, 2, 3. Chris is here. Oh, there he is. Good morning, everybody. Do I transmit okay? Come through? So this is a particularly unusual time in that I think that there's wide consensus that we're about to see some major changes in healthcare, the delivery and the financing, and there's almost or much less consensus about what those changes are, and that's a rare juxtaposition. But it seems a particularly good time for a panel like this, a propitious time, to get past the rhetoric and to think about value and how we might achieve that value in healthcare. And I've also charged the panelists offline not only about value, but about costs. The costs that plague us federally for the Medicare system, in each state for Medicaid, and in each home for affordability. And to think about how we might move past that, and they'll be doing it. We have 4 distinguished panelists today. Moving down in order, Joe Antos is the first. He's the William Taylor Scholar at the American Enterprise Institute. He's a commissioner in the Maryland Health Services Cost Review Commission and former deputy director at the Congressional Budget Office. Chris Jennings, I know from long association, is currently the president of Jennings Policy Strategy, a distinguished career in Congress and in the executive branch. He served as staffer in the Aging Committee with Senator Pryor and others, and then spent a long time in the White House, where he's at one point congressional liaison for the First Lady, Mrs. Clinton, and the president's leading health advisor, and spent that time. Alan Weil is executive director of the National Association for State Health Practice, former director for the New Federalism Project at Urban Institute. And Gail Walensky's had a variety of very important and influential roles in government and advisory areas. She's currently at Project Hope, but was chairperson at the Medicare Payment Advisory Commission. She served as administrator of the Healthcare Financing Administration, and again was Mr. Bush's lead healthcare policy advisor, and many other roles that I'm omitting in now. So I'm going to turn to our panelists to first make some sequential comments about the opportunities they see, the challenges they see, and the directions we might take. Then I'll start an interchange and invite you all to join with us in that interchange. Joe, please take it from there.
Okay. Well, let's see if this, yeah, that's a bad microphone. Okay, so how much time am I supposed to kill here?
12 minutes, 31 seconds.
All right, excellent. Okay, so I'm going to use 31 seconds to say that Tom Scully didn't get enough credit. It wasn't just that he was administrator of the Centers for Medicare and Medicaid Services, but before he even got the job, he announced publicly, I thought it was one of the funnier moments, in front of a crowd of a couple hundred people, that he was going to run a contest to find a new name for HCFA. And once he got that name, they were going to change that name every time somebody figured out what that agency was. So, Tom, I think it's about time to change the name.
HCFA is still available.
Well, you know, oddly, HCFA is now appropriate, kinda, because CMS now is the king of all health regulation. You know, those states don't really matter. You know, back when it was the Healthcare Financing Administration, it merely had Medicare and Medicaid. Now it's got everything. Anyway, okay, so just a few quick comments. I thought you were going to raise your question about cost, so I'm going to say something about cost. The only thing we can be absolutely certain about is that we don't know what's going to happen. We don't know what's going to happen next year, except for one thing. We can count on one thing, and that is whether you call it cost or spending, healthcare costs will rise. In spite of everybody's great efforts. The uncertainty, I think, is pretty tremendous. In spite of things that you hear from the administration, it really is unclear whether the Affordable Care Act will really roll out on the schedule. The continued inability of Congress to face up to reality in Medicare, I think, raises a lot of uncertainties. It's not just physician payment; it's everything. And then, of course, there's the sequester. That 2%, that's going to look like a great deal next year when it becomes whatever it becomes. The budget focus in Washington, I think, places the emphasis on all the wrong places. You see this in the ACA. You see this in everything that they talk about. Budget savers rather than improvements in policy, improvements in the structure of the healthcare system, or at least in the government programs. You don't see any changes there. Obviously, a lot of impatience on the part of Congress, which demands savings now rather than over time. And as I think everyone knows, any good policy, anything that really changes anything, takes time to deliver. You're not going to get it the first year. You're not going to get it the fifth year, probably. But we need savings right away. And then, of course, there's the emphasis on the government doing something. You've got to do something. when the government, in fact, has neither the prescience nor the control to make it work. It depends on everybody else. But that doesn't mean we can't do anything. I think it does mean, however, that we should be modest in our claims and realistic about the role of government. But of course, it's an election year, so forget about modesty and realism. Now, a few quick words, I guess, about the programs. Medicare, largest payer. It's the only program where the federal government has any leverage. And nobody has any leverage over Medicaid. So it's right to look at Medicare. And the ACA didn't do that. The ACA didn't change anything about Medicare. The ACA just said, you can disagree with me. Yeah. I mean, there are some nice ideas in there. They're not new ideas. 25 years ago, I was working on some of them myself. It takes a long time to come up with bundled payments. ACOs, we did a demonstration on that. The CBO didn't think that came out too well. Doesn't mean we shouldn't try, but my point is that when people say that the private sector is behind the 8 ball, gee, I look at that experience, and maybe people don't know that experience. Maybe they don't know it goes back that far, and it probably goes back further. But in fact, everybody's behind the 8 ball. So where is Medicare? Where is the government initiative? I don't see it. I probably used up most of my time. Should I say anything more? One thing about the ACA then. Okay, so this is my view of the uncertainty of the ACA. It's one thing for administration spokesmen to say they're just waiting. Those states are just waiting until the election to figure out what to do. And some states have even, some governor's offices have even said that. But you know, the exchange function is something they've never done before. I mean, even Massachusetts, which has an exchange function, hasn't really done this exchange function. I'm not worried about Massachusetts. I'm not actually worried about a few other states, Maryland being maybe the prime example of a state that actually got started before the law was signed, and it's a state that believes in let me call it close government collaboration with the health sector. I just retired from being a free market rate regulator, and I can tell you that doesn't work, but I'm not sure that's going to last that long. It's only been 30 years so far. But the question is, what's going to happen next year? And one of the things that people haven't really focused on is that there is no penalty for anybody to miss the deadlines. Certainly CMS has missed deadlines all over the place, and they haven't been penalized, and they won't be. I'm not saying that they could have met those deadlines, but they haven't done it. And the states can't possibly, many of the states can't possibly meet those deadlines, and the only debit on that is that some of their people, some of their citizens won't be able to buy insurance and get a subsidy through the exchange. By the way, I am discounting the federal exchange. We haven't seen any sign of it. It may already be too late. And the fact that CMS has pushed off some of the decisions to the states in guidance, not regulation, tells me that they really don't want this. So what's going to happen? I think a good prediction is that a second-term President Obama is going to say, it's going to sound like a Republican statement. He's going to say, we have to let the states go at their own pace. And why? Because you can't make them go any faster than they can already go.
Chris?
Well, thank you very much, Arnie. And you know, first of all, let me just say, Jeannine, thank you, and Tom, and Senator Daschle, and I don't know if my neighbor Blanche Lincoln is in the room, but thank you all for having us. You know, sometimes I listen to Joe, and I'm reminded of one of my favorite comedians, and it's Steve Martin, and he always said that the great thing, he played the banjo, and he said the great thing about the banjo is you can't sing a depressing song on a banjo. Joe could sing a depressing song on a banjo. So let's, moving forward, look, I'm actually so much more optimistic in terms of the discussion, the developments, the commitments than many other people are. There's no question that there's still huge challenges left on the healthcare cost containment front, but I think it's really important that we define what problems that we're trying to address. Whether we're talking about public or private or system-wide is one issue, because that's really important in Washington. Sometimes we get so focused on the federally driven approach when we really need to address system-wide approaches, and we tend to do budget-driven rather than healthcare-driven policy. And we really do need to do system-wide. And frankly, it's not going to be public, it's not going to be private, it's going to be a combination of both. And if we don't understand that, we're not going to succeed in what we all say is our ultimate goal. I do think it's important to note that today, not yesterday, not tomorrow, but today, cost growth in the Medicare is now at GDP per capita. It's actually below GDP per capita. Medicaid is rather constrained historically. Private sector grew at rates of 4%, very, very low rates, in fact, almost unprecedented historically. Doesn't mean that that's the trend or that's secured for the future. I would suggest that it's not. Senator Daschle and I worked with the Bipartisan Policy Center. We released a report yesterday where we completely acknowledge the growth rates projected even by CMS that are projecting a movement towards a 20% GDP growth rate and over $5 trillion in 2021. So clearly we have much work to do. But it's important to note that where we are is where we want to be going forward. And now we have to figure a way to secure it and ensure it going forth. So a couple things. The idea that we would go backwards on some of these success, to me, just seems ludicrous. The number of policies that were, by the way, crafted and drafted on a bipartisan basis prior to the time that this was falling apart in the latter part of the summer of 2009, were not really there wasn't a debate about them. We were all talking about delivery reforms. HIT platforms, investments there. Newt Gingrich was one of the great leaders. We talked about measurements for physicians and other providers and patients so that we could actually measure what works and what doesn't. That was not a Republican or Democrat. In fact, Gail Walensky was one of the leaders in this area. We talked about wanting to move forward towards innovations and more approaches away from fee-for-services to capitated payment. And now we have a very substantial expansions in ACOs. In fact, today we have over 150 separate ACOs serving 2 million people already, just 2 years later. And let me tell you something, even before the law of the land was signed in 2010, the systems were already changing. Hospitals, go talk to any hospital system in this country. I mean, they're moving, they're adapting. They know that the whole future is about, I will not survive if I cannot deliver care more efficiently and have better outcomes. Period. And it's happening. And it's very, very exciting. Competitive bidding. I mean, you want to talk about bipartisan? Tom Scully, Gail Walensky, Chris Jennings. We've been talking about competitive bidding for years and years and years. Everyone talks about it. Congress tells us not to do it after we get it enacted and authorized. Every single time. Guess what? We had a window where we actually got done. Guess what? We got bids. Guess what? They were 34% below what CBO had projected they would be. I mean, my goodness, this is happening. You just have to let people do things, and guess what? Things happen that are very, very positive. There's lots to come, even in current law. The transparency provisions that are going to happen where people are actually going to see what their benefits are and how much they cost are coming out this fall. We want to stop that? Do we want people not to understand how they can choose things? The idea about this high-cost plan assessment, which, by the way, is a Republican concept, tax exclusion, you may want to do it more aggressively. We can talk about that from a policy perspective. Do we really want to take a step back away from that? Is that really what you want to do? We talk about the new and inevitable competition from exchanges. Where did exchanges ideas come from? They're Republican concept. Pooling, private purchases, competition. Well, my goodness, now we're going to say they don't work? I mean, give me a break. Listen, we got a lot more to do. But the first thing we don't want to do is repeal the Affordable Care Act. And let me just tell you, the idea that we would repeal the Medicare savings from the Affordable Care Act, as Governor Romney has been suggesting, it will only increase costs further. Will increase premiums. Will undermine the solvency of the trust fund. What are we talking about? What planet are we on? Now, come on. This is good stuff. We are making real progress. Now, yes, there's more to do. I want to tell the Congress they have to stop doing the inconsistent messaging about what they want and what they don't want. Do they want competitive bidding or they don't want competitive bidding? Do they want dual eligibility reform or do they not want dual eligibility reform? We can talk about the different messages we're getting from both Democrats and Republicans on that. Do they want to do readmission policies or they don't want to do readmission policies? Do they want to do fraud and abuse enforcement or they do not want to do fraud and abuse enforcement? Do they want to let measures funding expire or do they want to make that commitment continued? Now, if they do want to do all those things, we can do even more than we already are, and we will. Yes, there are many more other forms I can talk about later. I know I'm going over, but let me tell you, the news is far better than Lake Wobegon is suggesting.
And I was upbeat.
The end.
Together, you two guys sound like two weathermen. Like, get the news at night.
Yeah.
I go to 4 and it says it's raining. And I go to 5 and it says, don't you worry, it's going to be nice and sunny tomorrow.
I'm Sunny, I'm Venus, and he's Mars.
Alan Weil, it's time for you to get out there.
Yeah, well, I'm always glad when some state perspective is included in a panel like this, which I guess is the role I'm supposed to play, although I will note, when I got to the front door, my name wasn't on the security list. So I'm not, and I think that's a little bit how states feel, is that, you know, they're invited, but they're not quite on the same terms as the rest of the participants. It is, I think, at the state level as at the national level, easy to view all of this purely as a budget issue, and it is, but I think at the state level there is growing understanding, as there often is nationally, that what's driving the budget problem is an excess cost problem, and so the starting point is excess costs. Budget problems are a consequence of that, and that lets you approach this set of issues and possible solutions somewhat differently than you would if you just saw it as budget. So what's the view from the states? Of course, it's highly variable, as it always is, but in broad strokes, we are coming into our third year of increased tax revenue, but it's coming out of such a depth in the downturn that states have not even returned to where they were before the downturn. And what we have is built up 3 or 4 years of deferred priorities, education, public safety, infrastructure, and the like, that even as we see revenue growth, as long as health continues to take the large share that it does, it's continuing to crowd out other very important priorities for economic development. The federal requirement in the Recovery Act, then continued by the ACA, for states to maintain their levels of eligibility in Medicaid, has preserved coverage for millions of people, but because states don't have tools for cost containment or have limited tools for cost containment in Medicaid, what it's largely done is led to reductions in provider payment rates or freezes in those rates, exacerbating the gap between private and Medicare rates and Medicaid rates. And one of the challenges I think states confront and the Medicaid program confronts is that, on the one hand, last week the Institute of Medicine tells us a third of the spending in the system is of no value, and then we look at a Medicaid program that's already paying so far below market rates, and you say, how do you square this circle of trying to take money out of a system that's already very underfunded but also has potential inefficiencies? And I think that's a really interesting area that states are putting a lot of their attention. The federal government, it has, in these tough fiscal times for states are cutting back on staff, furloughs and the like, although those days are mostly over. But from a state implementation perspective of the Affordable Care Act, the federal funds have mostly been for the coverage components, bringing up the exchanges, improving eligibility enrollment systems for Medicaid. There's some, depending on whether you listen to Joe or Chris, there's either nothing or a tremendous amount happening on delivery system reform in the ACA, but whatever it is that's happening, and I would lean more to Chris on this, it's largely driven by the federal government, and so the resources from the federal government to the states are mostly on coverage, not on steps that are designed to bring out the excess costs in the system. And there's just a lot of fear about the future, which leads to states being uncertain about whether they want to take up the now, due to the Supreme Court decision, the option of expanding the Medicaid program, and whether or not the federal government will really stick with its bargain in the ACA of 100% funding of the new enrollees for the first 3 years, dropping to 95, and whether 90 is really the long-term number. I would also note that the growing costs in Medicaid are really more due to demographic issues, increased prevalence of disability, and 10 or 15 years from now, a big bulge of people of nursing home age, and that's really the risk. It's not so much the moms and kids, or mostly adults, who are in the optional expansion population. So that's the backdrop. There's a lot of good news, I think, in terms of states' efforts to try to pull out these excess costs. We've seen sweeping the nation in the public and private sectors the move to patient-centered medical home. This is not a silver bullet. It is not a single model, but it is indicative of the kinds of efforts that are being made around the country. Investing in the primary care infrastructure is certainly not a solution to our cost problem, but it's definitely a necessary, even if not sufficient, condition for that progress. We see, Chris alluded to the efforts to improve care for the dual eligibles, those low-income elders and some people with disabilities who are eligible for both Medicare and Medicaid. I think there's a tension about how quickly we reform that system, but in general, states are enthusiastic to see, after 20 years of saying we need to actually do something about this, to see some changes occurring despite concerns about the pace and scale of that. And increasingly, states are interested in participating in multi-payer payment reform efforts designed to drive different incentives in the healthcare system. And just next week, states have a due date of applications to the Center for Medicare and Medicaid Innovation for the state innovation models, which is a $250 million investment in multi-payer system, multi-payer payment reform designed to improve population outcomes, and investment in delivery system reform that states have frankly never seen. So where are we going from here? You know, there's this election coming along. I guess I would just offer a slightly different perspective on where states are with respect to implementing the law. There are a dozen states that are poised to implement, and they have a coherent collection of policies framed by the Affordable Care Act. It's a dozen, it's not 50, but it's not just one, and I think we will learn a tremendous amount from that. I think the question to the other states that they will have to confront fairly soon is, can you come up with an alternative framework for delivery system improvement that's an alternative to the ACA, that's an alternative to covering almost everyone, that's an alternative to expanding public programs for the lowest income, that's an alternative to setting up a, you know, maybe more regulated than some would like exchange. If you have another model, then I think we could see some of the excess costs come out of the system. But if you don't have a coherent model, you're not addressing excess costs, and then you're just treating this as a budget issue, which is exactly the failure we see at times at the federal level and certainly at the state level. And I think that's going to, over time, that's going to prove to be a far less satisfactory approach. And to those who question whether or not the exchanges and all the other aspects of implementation will be up and running, I guess I would just toss back this question, which is, what core functions are you really thinking they won't be able to perform? I understand that the vision of an exchange and integrated eligibility between tax credits and Medicaid may be a little more complicated than we're all going to be ready to do January 1st of 2014. I've already told the reporters to file their stories for January 1st, 2014 for how terrible it is, just like it was terrible when Medicare prescription drugs were unveiled. It was a disaster, and yet it's not now. And so the question is not, is January 1st going to be nirvana? The question is, are we going to be making enough progress that people notice it? And which functions are not going to be up and running? It's hard for me to see core functions of plan availability, core functions of eligibility enrollment. Anyone who wants to get that up and running by January 1st, 2014 is certainly able to do so. So I'm optimistic also about the emphasis we're placing now on cost and excess cost as opposed to just budget, and I think that not the way most states are looking at it, and that's why I think the efforts they're making are generally pointed in the right direction.
It's not often that Alan Weil gets to not be the last speaker, so he's always happy when I'm showing up. I'm going to go back to the issue that Arnie asked us to focus on of looking at whether or not costs are being changed, impacted as a result of either the legislation or what's going on right now. And to say that what we see is a spending slowdown. But what we don't know is whether we're really having a lot of impact on cost right now, and we need to understand that those are not necessarily the same. We clearly are seeing a spending slowdown. That's been observed by a lot of individuals. It's been noted that the spending slowdown is more than what we've historically seen given the level of per capita income decline that occurred in the recession. That is also correct. I don't think there's much debate about that. I think we have not paid quite as much attention to the fact that this is an unusual recession as it relates to this issue, because there was not only widespread job loss and therefore income loss, there was an unusual hit to the wealth of the middle class because of the hit not only on the 401ks, but more importantly, the really devastating blow to housing values, which for most Americans is a majority of their wealth. And it is not only income that affects spending, but it's wealth that affects spending. And I think when people have noted over the last year or so that the reduction in spending on health care is more than you'd predict from reduction in income, they really aren't factoring in the change in wealth that has occurred. Having said that, there's certainly a lot of activity going on. There's been a lot of activity going on from around 2005 or 2006 in the private sector. A lot of activities of big plans, the for-profit plans, the blues plans, trying to designate high-value providers, institutions, clinicians, trying to encourage people by lowering premiums or lowering coinsurance payments to make use of these. We don't know how much effect that's having. It's very hard to tell in the aggregate. We see a lot of pockets of activity, but it's hard to see whether or not that actually aggregates up to a lot of change or not. The real question to me is if some of the slowdown is more than primarily reflecting the recession and the reduction in wealth, is it sustainable? And that's really, we need to be very clear and open. We do not know the answer to that. And there are really two reasons for that. I want to try to make these clear because I don't hear them discussed as much as I think they should be. The first is we should not confuse lower reimbursements under Medicare with lower costs. We are having savings in Medicare because Medicare is going to pay its institutional providers less. It hasn't figured out what in the world to do with the physicians. And when it does something, it will probably go $300 billion in the hole. But we have not reduced costs for Medicare. We are just planning over the next decade to pay them less. Now, there are a lot of reasons that people are hoping that might drive institutions to change their behavior, that some of the pilots that are just beginning to go into effect might allow for more efficient ways to provide services. But we have to be clear, when people say, correctly, Medicare spending over the course of the next decade is going to be about the per capita level, it's not because they've actually figured out how to have that happen. That's just what they're going to pay. And the question is that sustainable? And the answer is probably not if we have anything to say from history, if that's all that happens. We've tried that trick before, and it usually falls apart. And in fact, one of the other points that I want to make is this is not the only period when we've had a spending slowdown. Not nearly enough attention is paid to what happened in the 1990s. 1990s, we had two successive periods of slowdown in spending. From 91 to 97, we had a very dramatic slowdown in the private sector. In fact, in the middle of that period, 1994 to 1996, the growth in private sector spending was less than the CPI. Now, Medicare was going crazy during that period, so total spending was actually more than the growth in the economy. But it was actually under that. Now, what was happening? Well, you saw very aggressive behavior by the employers and private payers toward managed care. It was really managing costs. There was very little managed care that was going on. And it was effective, but it was not much appreciated. And so by 1997, you started having all this managed care pushback. Congress was having its hearings on how many days women needed to stay in the hospital postpartum and other things that Congress thinks it should opine on. But the message to the
Goes both ways.
managed care companies was lay off. People are not happy, to which case most of the private payers said, fine, we know how to do that. If you want easy access to specialists and technology, we can do that. Now that was followed almost, well, it wasn't even followed, almost at the tail end of that activity, we had the Balanced Budget Act, which reduced reimbursements across the board to institutions and clinicians providing services to Medicare. And for 3 years, it was very powerful. And by year 4, after Congress had started giving back some of the money, things were back to where we were. And in fact, now we talk about the decade of the 2000s as though, you know, it was just only increased spending, forgetting that it followed this unusual period where healthcare spending started and ended at about 13% of the GDP. Now, I don't say that that's necessarily our future. It's not. It's to remind us that it's one thing to find savings, and it's an entirely different thing to make them sustainable. And that's where I'm more worried, and there are really 2 reasons that I'm worried about that. The first is that I like the idea of pilots. I mean, you know, we did, after all, introduce the relative value scale without even having it finished, yet alone trying it anywhere. That was maybe not the very best idea. So trying pilots is a good idea. The problem is there are a lot of steps that have to happen, and they have to happen fast. You've got to see, does it seem to work the way you thought it did? Is it scalable? I mean, it's nice if it works in Dallas, Texas, but, you know, is it going to work in Detroit, or is it going to work in Los Angeles? If you find whether it's scalable and it's replicable, then do you make it happen? Those are a lot of steps. There's nothing in the legislation that is a forcing function. I would have allowed, rather than permitting the secretary to do various things, to have a trigger that unless certain bad things happen when costs are lower and quality is improved, they at least go up the scale of being scalable and replicable. That would have made me feel like it's more likely that something good would actually get enlarged. It may be a little bit of been there, done that, too much jaundiced of the Washington experience. So I think we need to be very careful that that part goes ahead. The other, and this is really the point I want to end with, is there is a fundamental division of opinion, even among reasonable, responsible, knowledgeable people, about how to slow spending in healthcare. And it's become clear there's just a different orientation. In an NPR interview that Don Berwick and I did in August on slowing Medicare spending. Now, both of us received a number of calls saying, this was out of the Boston WBUR show On Point. And both of us received a number of calls from people saying, boy, it was really nice to hear 2 people who obviously respected each other, are knowledgeable, who disagree but could do so in a civil manner. And what became clear over the course of that debate also was, I think, was clear but maybe not quite as much a direct juxtaposition, was the pair of articles that was in the New England Journal. It was published a week or 2 ago that Joe Antos, Mark Pauly, and I did on one side, and Zeke Emanuel and 22 of his best friends did on the other side, about how to slow healthcare spending. And the question is whether you can successfully do that without directly involving the patients. And I think there really is this difference, which I've discovered, that in talking with people like Don Berwick, his attention is how to make the delivery of health care better. And I think it's obviously an important part of how to solve this problem. We know that the reimbursement has been, not just unhelpful, but positively perverse in terms of rewarding more and more complex, not having people have good health outcomes or stay healthy or improve quality in an efficient way, and that we need to do something to fix the delivery system to reward coordinated integrated care and good health outcomes, and think, it's hard not to think that would be a better idea. But it's really a question of, can you get this job done without much more direct involvement of the patient? And that's where there seems to be a difference of opinion. And it's why people that tend to be I would say, on the right, sometimes, not always, in the middle, tending not to be on the left of center politically, have latched on to this issue about premium support or some way to fix amount of a subsidy, to do it with refundable tax credits, to do it with a fixed subsidy to seniors, to try to get them much more directly involved, and also making it very clear to the payers and the providers of services that there are many parties looking to see what they're doing and how they're doing it. And there really is this difference of opinion about, are you going to get the problem fixed in the under 65 or the over 65 if you don't involve the user, patient, chooser of a health plan in a much more fundamental and integral way. And that's a problem we're going to have to solve. I don't personally think we're going to get this problem fixed if we don't. Reasonable people who I know understand, probably in the clinical sense, much more than I do about the delivery of health care, don't agree. We need to have that discussion in a much more serious way. This is not the time. Elections don't lend themselves generally to good, thoughtful discussions. This discussion, of course, aside.
I want to thank all the panelists for their initial remarks. Do I transmit in the back on this receiver? I hope one of these is working. This one works? Okay, we're there. All right. There. I've got it. I do want to thank you folks. I'm going to lead off the questioning to start the interchange, but there are many, many very knowledgeable people out in the audience who I'm seeing, so I'll soon turn it to let you get involved yourselves, either for brief comments or questions. The panelists together have spanned the banjo playing and on to tell us that all may not be right, that there are questions about ACOs and there are questions about bundling, and there are certainly questions about whether changing the price of services really means anything in the long run, things we care about. I take Gail's point about the need to get move sort of pilot projects into practice more easily, and potentially the need to get patients involved. I want to give the panelists a chance to reflect further on these. Joe and Gail did write, with Mark Poley, a terrific paper in the New England Journal about their views, and Zeke and 22 of his friends also wrote a very thoughtful paper. Joe, let me turn to you, but really move down the line about, apart from what Gail's already mentioned about moving pilots in more quickly and about issues about getting patients involved, what other kind of changes do you think might be helpful here?
Thanks, Arnie. Thanks for the compliment as well. Just a few quick responses a little bit. By the way, I'm not a spokesman for the Romney campaign. You could probably tell. So
fewer people are acknowledging that now.
Right, but I was early. I was early in that, yeah, a lot of people are going to be doing that. My comments weren't that there wasn't activity. My comments were that when you look at the evidence, you can't say there's a victory that's certain. That's the issue. So if you believe CPO cost estimates, which I used to work there, I don't, because that's, it's sort of predicting the future. It's very hard to know how things really change. But the innovative ideas didn't get much scoring, and I think that's a reasonable prediction. It's not that we shouldn't try to do these things, and this is part of the answer to Arnie's question. Absolutely. Just because we were talking about bundled payments 25 years ago doesn't mean that we shouldn't try to make it work. It's just really hard to do. And when we did make it work, of course, Congress didn't like it. It's very similar to the competitive bidding story. So, no good idea goes unpunished in Washington. And then Alan, on the point about whether the states can make it or not, I'm not arguing against organized markets. Obviously, you need organized markets, but it's not the functions; it's the possibility of getting the paperwork done in time. And an important part of the paperwork is that the health plans have to know enough about what's required in order to submit their proposals, and they have to do it by January 1st. And it's not January 1st. The deadline isn't January 1st, 2014. It's October 1st, 2013. And a lot of states really are behind the eight ball. You need authorizing legislation in the states, or regulation or something, and a lot of states haven't done that. So I'm just saying it's going to be hard to do, and I think it would be wise to face that reality. Now, what else would you do? As I said, I like all the ideas if they would work out. But in the end, we're really fighting against ourselves if we don't address something that the BPC report, which is an excellent report, raises. It's their number one cost driver is fee-for-service. Now, we're not going to change that in the private sector unless somebody takes the lead. And who's going to take the lead? I think it's got to be Medicare. Because Medicare, if anything is preserving fee-for-service in a way that's not helpful, it's the Medicare program. So I'm not saying fee-for-service is ever going to go away, but we need to reform that part of the program, and we need to change the basic financial incentives that health plans and implicitly doctors, hospitals, and all providers face, which everybody has sort of alluded to. Under the current system, it's not just that you get paid more to do more, but there's also the implicit promise that there's no limit on it. And I think that's the issue. So, on ACOs, I think that not telling a patient that they're involved in something probably isn't going to work, and not giving the, let's say, physicians, there are other providers, but think of the people who are more likely to be the decision makers with the patients, not giving them more ability to influence or direct health care. Especially, I'm worried about baby boomers who use the internet a lot more than their parents and are much more likely to say, well, wait a minute, I saw this doctor and I want to go there. Good luck. That's really going to be difficult to control. And a couple years later, when it all sorts out, there are going to be some very unhappy participants in the ACO project unless we do something else to change the climate in Medicare.
Oh, where to start? First of all, the BPC report on cost drivers was and is a good product. It is a documentation of many factors. Some 13 we explicitly talk about because we decided that it's important to define the problem before you try to develop the solutions. And I wouldn't say fee-for-service is the number one. It's listed number one. It's just all of them are they're all very important drivers. And what you learn about them, of course, is, and what we've learned about healthcare all the time is that getting to the interventions and understanding their interactions with one another are the biggest challenge in healthcare. Fee-for-service being altered, again, this is not an Obama-Romney thing, but the idea that we would repeal the very provisions that are doing just that. They're moving in the direction away from fee-for-service and talking about the different approaches. And look, ACOs are pilots. They're demos. They're meant to be expanded and to be learned upon and applied. Now, what Gail suggested, which I think is a very interesting suggestion, is you will recall that under the authority of the Affordable Care Act, the Secretary is authorized to expand nationally, but is not required so to do. Look, I would endorse that. Good provision. I mean, I think there'd be a lot of people who would say that's a good thought. I'm not sure a lot of Republicans would, but empowering the Secretary to do more is oftentimes a hard thing. And moreover, Congress, as you know, Gail, generally doesn't like to do that, which is the whole point why Senator Daschle has raised this whole issue in the years past about the need for more independence in the decision-making process. CBO. CBO was burned in costs in the 60s, 70s, and 80s in their projections. But if you look at them historically in the recent years, the 90s, the early 90s, the late 90s, 2003, in fact, many Republicans cite the 2003 Part D projections were overestimated in cost, that there were more savings than were initially projected. Well, that happened in 1997 too. It's happened in the last several estimates. They've been very, very, very cautious on projecting savings and actually underestimating and overestimating cost. Lastly, with the issue of patient involvement, I guess this is where I might just disagree a little bit here. A lot of, I don't think it's a question of left to right. Patients desperately want to be involved in their care. In fact, we need to have patient-centered care. The question is, do you give them the information and do you empower them to do that? That's one question. The second issue is, do you make it unaffordable for them to access the care that they need? And that's how, it's the issue of how much risk does each party bear. And that, I think, is the distinction. It is, I think that there's some people on the right who are willing to put more risk on patients, and some people on the left who are more concerned about that. But that's a debatable point about how high you go up the income scale. We can talk about that you can have an informed and complicated conversation about that. I don't think if you have a rational conversation, that can't be bridged. So again, I'm very, very optimistic if we can have these types of conversations. I think Congress has to follow its rhetoric and empower people to do the interventions that they need, and if we can really make some significant and sustainable progress. And I couldn't agree more with you that the current period of time could be a blip if we don't do that well.
Two comments. First, I mean, Joe, I agree that the timelines are tight on the exchanges. I just think that we have to ask what questions we're trying to answer. And if the question is it all going to work perfectly on January 1st, 2014, it's pretty easy to, even with a banjo, sing a really sad song. But if the question is this, remember, the primary shift for people potentially on 2014 is to go from uninsured to insured status. And the question of, well, maybe we aren't really quite ready for them until March, but they've been uninsured for the last 5 years. I don't know that those people are going to see that as a sad song. So part of it is I'm trying to figure out the question. And I want to follow on Chris's comment because, Gail, I wrote down the way you posed the question of the difference with Don Berwick is, can you do this without directly involving the patients? And I had a very similar reaction to Chris. I would frame the question something more like this. Can individual purchasers of health insurance in presumably a better structured market place the pressure on the healthcare system that's needed to make it more efficient? Or to frame it slightly different, which is the better method for pushing the healthcare system to reorganize towards efficiency? Individuals exercising their purchasing power or large purchasers exercising theirs? And I mean, I think it's easy to, it's both, but, and that's why I think it's hard, it is both. And so, and because my work has mostly been around Medicaid and public programs, I'm looking at a program, the largest public program in the country, with 42% of the spending on people with disabilities, with the most complex populations, and I'm trying to envision the world in which the appropriate risk-adjusted payment is made to the person with traumatic brain injury to find some risk pooling entity, whether we call it an insurance company or a plan or whatever acronym we want to give it, to to buffer the individual from the risk of costs associated with their condition, while simultaneously having that recipient of the dollars place the right pressure on physicians and nurses and social workers and dietitians and community-based organizations to figure out how to get me the services that I need in a respectful, personally appropriate way. And I have a hard time envisioning that. Whereas if you ask me, could you take a mass of basically, healthier, higher income people in a commercial system and get them to put the pressure on the healthcare system? I'm a little more skeptical. I'm probably more skeptical than Gail, but I'm a lot more open, not just from a risk, who's going to, is it fair to give people that risk, but in terms of really the likely outcome, because we can push down the price of, we can't push down the price of an iPhone, that's clear, but we can certainly push down the price of technology, but it's coming from not just an information, not just empowerment, but from a fairly standardized product. And what I see in healthcare is that what the high costs are the non-standard products. And so that's, I think, so I would frame the question differently, and I guess in the end I'd probably answer it differently as well.
I'm going to obviously come back to this point, but Chris made a statement that ACOs are demos and pilots. Actually, ACOs should have been demos and pilots. They are one of the few things that are in the legislation just as is. That's too bad. I think it would have been better to have them as a demo and a pilot because we don't really know what's happening. They're probably effectively going to turn out that way. They're not there. There are very interesting ACO models in the private sector that are going on that, of course, didn't need Medicare's permission because they weren't at risk for violating anti-kickback and START provisions. So that was just a small point. Second point that was made has to do with the triggers, and I certainly am not going to say whether our friends in Congress would like it or not. There is some precedence for the Congress doing that. There have been, at least in Medicare, some benefits that were expanded provisionally, subject to bad things not happening. So it's not without precedence that you have a trigger mechanism rather than a permissive mechanism. It's my concern that having occasionally seen some good pilots and demos, they have frequently not worked out the way people thought, but sometimes they do. They tend to languish, and that's my concern. And it's not because they're bad people that are just ignoring them, but it's somebody else's pet interest that is now focused elsewhere, and that's really my concern for not having a trigger rather than having just permissive. We go back because I will take it as you're not taking it seriously, but that we are just looking at this differently about how you and Chris describe this issue about the role of individuals. We are not talking, people who talk about premium support, which, some very well-known D people have been known to support premium support. We're not talking about, here is your money, go and call your broker and see what you can do. We're talking about using your subsidy dollars, however they're defined, to go in a structured market and to purchase plans that meet some criteria. And the question is, when you know you have a fixed subsidy as opposed to an open-ended subsidy, will you also, as the purchaser, be interested in what it is you're buying a lot more than in the current Medicare system, where if you have Medicare and a wraparound, which is almost everyone, some kind of public or private wraparound, you now know you can go in and see a physician that will see you. Not all physicians will, but many will, or go into the hospital or go into various other settings. You do not have, you're not armed with any information. I'm all for we have to empower people so they know what they're buying. They have an idea about who are the good clinicians, which are the good institutions, who does well on their diseases. But they need to know something that plans differ. And they differ in a variety of dimensions. And it may make a difference, according to who you are, as to how they differ and which ones you're going to be attracted to. And that's really the question. Do you mean that you think most people in the United States are disabled, some of the very high risk? We can discuss whether they're likely to be better off if they could, in fact, vote with their feet on the plans that are delivering services that are designed for them or not, but they're a special problem. But for most Americans, that if you give them information that they can also be helpful in pressuring plans to provide the kind of services they want, might not be what the clinicians think are important, probably won't be, but it is important to what these individuals are. I just, to the core of my belief, do not think we're going to solve this problem if we don't get that kind of consumer involvement and all the other things about getting people incented to eat better, exercise better, all those other good things in terms of lifestyle. But it really does go to this fact, can you get the problem solved without actively involving people? And when they choose plans, I'd like to get them a lot more armed with information before they're making a major medical decision in terms of intervention of some sort as well. Some will use it, many won't.
Chris, you wanted to make brief comments,
Yeah,
and then I'm going to open it to the audience.
I mean, you know, again, we're not engaging in a political conversation, really. We're just talking about shades of differences here. But I do think it's confusing to people who must be watching this over time, this discussion over time, to say why people who oppose ACA are so convinced that exchanges won't work, and yet are absolutely convinced that a premium support model will. It's just, you know, so, and you can turn that on its head for Democrats. Well, if you think exchanges will work, why, okay. But I'm just saying, this is a, you know, so what describe, how do you know, how do we reconcile that? I think one way is that there's also a policy political conversation about bringing people together on a very, very vulnerable population about how best to deal with them. Very, very sick and poor people and very, very old people tend to be more vulnerable in our healthcare system. I have an 89-year-old father, I'll tell you, it's different than I am. It's just, you know, just a very, very different capability in making decisions and all the rest. We have to know that those exchanges are set up and are working and working well, and aren't going to in any way discriminate or design a package that will avoid very sick people. Now, I'm not suggesting that you would design something that would do that, but I will just say that there is a second order of interest and concern about that. So one, as a logical question, why wouldn't we make sure these exchanges get working and operational for the broader population who tend to be a little bit less risky here, and make sure it works and is designed. And if it does, then and the population becomes more comfortable with them and using it, then maybe you think about alternatives and you make sure you get all the protections right. And you know how many protections that are going to have to be designed to get this thing done right. And I would argue with you that that will be the debate. It will be what level of protections that you can provide, what kind of options you give the plans to design their benefits. You suggest that all Republicans are all about, you know, we're going to have a defined benefit and they're just going to compete on these certain benefit packages, and you and I both know that there will be a complete difference of opinion about what those designs are and what the appeals process will be and what the risk adjustment payment rights and what kind of exposure to cost will be. And those details are really important to human beings. And we can talk about this and that, and this is a better philosophy, whatever, but it just strikes me that, you know, yeah, I plead guilty to making sure that very vulnerable populations are protected.
Gail, did you want 30 seconds to do before we open it?
Again, as the notion, Joe said it first, many of us market-oriented economists do not have a problem with structured markets for insurance. We have a lot of question about how much regulation is imposed on them. The question is, do you allow much variation or not much variation? Do you get yourself in a position where you have in legislation the 10 Medigap plans that people can buy if they're over 65 to wrap around. And God forbid you want to have a value-based insurance design, which now seems to be sweeping as a good idea. Well, Congress has to pass a freaking new law because it's not allowed, because it was thought we'll just put in legislation those 10 plans. It is the concern, that kind of concern, it is all in the detail, and it's the kind of thing that, of course, it's complicated to work out. So is spending $600 billion on Medicare and trying to figure out what to do with it.
And so is cutting $800 billion from Medicaid. I mean, complicated too.
And at this point, let's open it up. Larry? And if you don't mind, if you could identify yourself, I'd be grateful.
Yes, thank you. I'm Larry Gage, partner in Ropes and Gray for another week, and a partner here at Alston and Berg after that. I am also a past president of the National Association of Public Hospitals Systems. In that role for 30 years. Now I know all the people I know in this room. I have about 5 points, and I'm going to try to roll a bit of one question. So I'm going to start with the patient dichotomy that you're talking about up here between Don Berwick and I guess folks who have patients who are much more engaged in selective health plans. And I guess I think there's a middle ground. And maybe the middle ground is an interim step, and maybe it doesn't focus on those patients who really aren't at risk or don't have a lot of health problems in the middle stages of life. But I think we have opportunities that we may be missing, and we're missing them in part because, number one, Medicare and Medicaid absolutely must cooperate because many of these patients are the so-called dual eligibles, and they have chronic diseases. And I think what Don Berwick would say if he were here is that his position has not so much been misstated as overly simplified, because I think Don very strongly believes that a patient who has asthma, or a family of a patient who has asthma or diabetes or COPD or any chronic condition needs to be intensely involved with providers and ultimately with health plans in the management of their care. And that will maybe cost more in the short run, but certainly reduce costs in the long run. So the question is, how do you get Medicare and Medicaid to better coordinate with one another around all of these good ideas that are welling up in the states about health reform and reform of disease management? And by the way, Alan, what do you do about the states that simply aren't going to participate, and what do you anticipate is going to happen with those states over the next couple of years?
So if the mic didn't work well, to boil it down, it's how do we get Medicare and Medicaid to come together? And for Alan particularly, what about the states that don't go in?
We ought to think about having a pilot that has Medicare and Medicaid as a single program for low-income complex people with different benefits and subsidies. We already do. We keep walking into that when we have for Part D special subsidies for the people who are below 133% of the poverty line. We have the Slimbies, Quimbies have their own little additional programs now. It needs to be a single program. At the very least, it needs to be two programs joined at the hip as opposed to two parallel programs that never talk to each other, which is basically the case for the dual eligibles. I think it would honestly, we ought to try and see what happens if we modify, you make it into a larger integrated package for individuals who meet these qualifications, but you make it into a single program. I think we're just fooling ourselves otherwise.
I certainly, and I've written that we need a separate program, and I think what is so shocking, because both programs are so large, most people in the policy sphere live in one or the other and have no idea how differently the other program views the world than the one that they're in. And the misalignment in benefit design, in provider in the payment, and the fundamental one that I think is the biggest challenge right now to the demonstrations that are going on is fundamentally different views about patient choice of provider. That Medicare starts from the proposition of free choice, and anything that you might do to a dual that would constrain the choice, witness the ACO experience, is viewed as takeaway. And back to Chris's point, so you're taking Medicare benefit benefits away from the most vulnerable. That's real appealing. And on the Medicaid side, where you have a long tradition of limited choice and full because it's the lowest income people, you've got little or in many instances no cost sharing, and limited networks because, as you know, the payment rates are below market, and so you get experts like your former organization's members who know how to handle this population. Other people run away from them because they don't know what to do, and it's a complete and to them the notion that you can't lock them in, you can't assign them, you can't do management. This makes no sense. And so at the end of the day, you have to pull it out of both of those cultures and create a third culture that is an integrated culture. That, of course, rolls off the tongue nicely. It doesn't get written in legislation quite as easily. But I would just close with sort of the current debate over the duals is, I think, again, a perfect microcosm of the two different worlds from which the programs come, because Medicare is used to demonstrations. 5-year design, 5 years of data collection and analysis, a report written, a conclusion, 5 years of delay in doing anything with it, and that's how innovation occurs in Medicare. And
you and Joe are close friends, I see.
Right. And Medicaid is used to, I went to a meeting and someone gave me a good idea, I want permission from the federal government to implement it tomorrow, without any evaluation component and without any real data to support it. And in fact, both of those models have something to say for them and some limitations. And I think what we're seeing fought out in the dual demo is the sense of how do we think about a demonstration for 2 million out of 9 million people, which is certainly big by Medicare standards, but is a lot slower than many trends have swept through Medicaid. Where's the data component, the evaluation component? What do we do with the results? Do we push them out in a mandatory way to the other 7 million if it's a wild success, or is it up to the states? I think we're seeing the culture clash not just between the two programs, but also in the debate over the structure of the demonstration.
Can I just one quick about this? This is sort of it is a great example because. So finally, you have this former governor, Secretary of Health and Human Services, saying, "Okay, I want to do a demo. I'm going to try to go as fast as I can go to make the states happy without alienating." Okay, what happens? Well, she gets criticized from the right and the left by Congress. Both the Republicans are saying you're going too fast, too quick, slow down, which is sort of interesting, and the same thing from the Democrats. Now, I think they're going ahead. My view is you either let them go ahead with appropriate protections, and I'm sorry, Democrats, or you say, to Gail's point, do a Medicare program, or at least a Medicare demo pilot, and do it now. Stop talking about it. We have been talking about this population. I can't remember when I haven't been talking about this population, right? I think it's incumbent on the federal government to either give the authority to do it or to take responsibility, but stop talking about it.
Joe?
Yeah. So Larry muttered pace. You didn't hear it, but he muttered pace. Okay, and this raises the other gigantic problem. You've only been talking about government. Let's talk about patients. Let's talk about my mother. She would have been a great candidate for PACE. Why didn't she want to go into PACE? Because she had to give up her doctor. That's the major reason why you don't do it. Okay, so when do you have to start this? Before you turn 65, before you get into the programs. We'll get there eventually, but we need more integrated healthcare systems, not at 65, at 25. And we don't have that. And then they also have to be able to participate in these government programs.
We're getting close to time. I'm going to ask Bob, who's asked the question, to phrase that, and then the panelists to make very brief responses because of time.
I'll try to be brief on you. Bob Patricelli, and I've had a career in health policy and then in the health insurance industry and as an entrepreneur. And for my sins, I now found myself working with doctors trying to reform the delivery system. So this is an observation and a question from the trenches. there is, in my view, a growing understanding among providers that we really do have to yank this atomized system into integrated delivery mechanisms that are being paid on some kind of shared basis. The only organizations that I see, and I'm from Connecticut, out there that have the management capability to start to work on those things are hospitals. And hospitals are, once again, as you know, acquiring physician practices, trying to move in the direction of these systems. And most health policy people would say, we're not so sure that's the way to do it. When you look around at docs, they increasingly say, we got to get together. We got to form multi-specialty groups, and we've got to arm ourselves with clinical integration techniques and all the rest of it. But where's the management? Now, we have great management in the United States, and it's in for-profit companies. But these companies can't get directly involved in healthcare delivery because of things like corporate practice of medicine and star pools and all the rest. So the market is unable to respond to what I think is a growing demand to try to move in the right direction. Have you folks ever really looked at trying from the federal level to override corporate practice of medicine so you could have Connecticut Physician Partners brought to you by Google, and an IBM healthcare plan, or a UnitedHealth delivery plan, etc. We need to get management into this system, and you guys got to begin to think about how to do that.
I agree very much with what you are suggesting. I am one of the people who've been increasingly vocal about my concerns about the trend toward more and more hospital consolidation, being augmented with more and more hospitals acquiring physicians' practices. It is possible that some of these mega hospital systems might wander into being a health system, an integrated health system. Some of the bigger and better ones as they acquire home care and nursing homes and others. For many of them, however, I think they are going to be mega complexes that are going to retain an interest in keeping beds filled and doing all the things that the rest of us don't think are great ideas for American health care, and that since most of the savings, the big dollar savings, are potentially coming out of the hospitals, they are the least likely places to offer up these other ways of integrating care, moving more out into the ambulatory setting and having a very different mix of services provided, much more focus on primary care, ambulatory care, and the use of expensive tertiary care facilities when you need them, lower cost secondary hospitals when they're appropriate. And I find it very hard to imagine many of these hospital complexes moving in that direction in any kind of voluntary way. You've been around here, you know, what's the likelihood of getting Congress to override state malpractice laws? I mean, they could, they rarely do. The one that is clear, the ACA has increased federal power relative to state power in insurance and taken over many of functions that were previously left to the states. It is an extra fight that really breeds odd bedfellows in terms of who's for and who's against, depending on the substance of the issue. But I'm concerned about ACOs because I do see them as one more way to empower hospitals. Yep. And I have desperately looked for physicians to mobilize and form multi-specialty group practices. But I don't disagree. They need management. We have a ton of management available in the United States. There's nothing about the market stopping it from happening. You know, you can't stop really bad government policies from existing unless overriding them with other government legislation. And that's the constraint, not the market.
How about Chris and then Alan?
Just very quick, to your point, Bob, when we released this report yesterday, you'll note that there is a specific reference to some of the antitrust issues and also and the consolidation issues that you and Gail have risen and or have raised, I should say. And you know, there's the challenge with this is there's positives and negatives with some of this consolidations. Some of it's more efficient, some can improve delivery systems, some of it absolutely could create major concerns in terms of increased cost. I think if we move towards a system away from some of the fee-for-service, some of that stuff gets taken care of, as you don't have the same incentives that you otherwise would have with physician-owned. You know, some of the physician-owned stuff is a problem too. My experience with PSOs that I don't know if people remember back in the 80s and 90s, everyone thought, oh, well, we want to be the risk-bearing entity, but they didn't want to manage it, they didn't want to bear risk. And they traded a lot to get the authority, and then they didn't do it. So I don't understand actually why the market wouldn't respond to that, because I do agree with you that physicians are increasingly desirous of moving in this direction, but I don't think they'll want to manage, and I don't think they'll want to bear risk. And so I think maybe you can tell me the bridge to get over that chasm, then I think you'll have a much greater success in seeing positive directions.
My only footnote to those two very good comments is that I think maybe we should think about management capacity here similarly to how we think about primary care capacity, which is that it's not a shortage of it, it's a misallocation of it. And we actually, if we had more efficient systems, if we used the people we have in the healthcare system more effectively, more appropriately, we could solve a lot of what is, if you just sort of count numbers, seems to be on a linear extrapolation basis when you're adding 30+ million people to the pool of people with insurance, insufficient capacity. And I just wonder how much of the current management capacity goes to coding and billing and kinds of things that frankly are of in the long run hopefully lower value in delivering the product we want. So it's just I agree with both of the prior comments, but maybe part of the answer here is to redeploy, not just to have to look elsewhere for it.
And Joe, you wanted a brief last word?
Yeah, just following up on Alan, absolutely. That's one of the problems with fee-for-service. We've got to change, we also have to change that. Otherwise, we haven't freed management.
This has been a wonderfully edifying panel, but we have yet two more that promise to be equally interesting and engaging. I want to thank this morning's panelists very much for their helpful comments. We're due to resume at roughly 1/4 of. It may be 2 or 3 minutes past that, given we run over. Towards the right side. So warm. So warm this morning. Good morning to you all. Thank you for rejoining us for what I think will be an equally interesting, engaging, and informative panel. I'm going to shortly hand the mic over to Julie Robner. Many of you know Julie Robner, at least her public face, if not personally. She's the NPR voice on health. She's taught us a tremendous amount about that, and with a lot of her expertise in health reporting. So without further ado, I'm going to just hand this over to her, and I think this is one that's working.
I have my own. Can you guys?
So we were at the Saturday.
Can you guys hear this?
Saturday we were here.
It sounds like it's working. So you leave that there in case we need it.
Hold on to 6.
Thank you very much. I am honored to be here this morning. I confess I wanted to come mostly because I wanted to hear this panel. And I'm mostly happy to be back with what I call my peeps. I've been handling the health beat this last month. We have a reporter on maternity leave. So I've been trying to do my beat and the health beat, covering the Farm Bill and the sequester report and all kinds of things that I know nothing about. So I'm much more comfortable being back in the healthcare realm. And as I'm sure you're all aware, there's been a little bit of discussion in the presidential campaign about this thing called healthcare, and in some of the Senate and House races as well, to help us explore where we are now, which seems to change about every 5 minutes or so, and where we might be headed. We've assembled an all-star panel, and I will not waste any time getting to them. You have their bios in your packet, and if you're here, you should know who these folks are, so I will keep my introductions brief. We have, in alphabetical order, because I don't know anything about protocol, Senator Tom Daschle, former Senate Minority and Majority Leader from South Dakota. These days, he's a Senior Policy Advisor for Government Affairs at DLA Piper. Next to him, Governor John Engler, who served 3 terms as Governor of Michigan, although I might add, after I left the state. Governor Engler is President of the Business Roundtable, a position he took over in 2011 after having served for 6 years as President and CEO of the National Association of Manufacturers. Sitting to his right is Senator Blanche Lincoln, like Senator Daschle, a former member of the Senate Finance Committee and a very knowledgeable voice in all things healthcare, dating back to her days in the House in the 1990s. Today, she's Special Policy Advisor at Alston and Bird. And finally, last but not least, Congressman Billy Tozan, who served as both a Democrat and Republican from Louisiana and chaired the House Energy and Commerce Committee. Don't laugh. He was one of, I believe, still the only member of the leadership from both parties. That's correct. Chairman of the House Energy and Commerce Committee when it passed the Medicare prescription drug law in 2003. Congressman Tozan left Congress to become head of the Pharmaceutical Research and Manufacturers of America, where he would ultimately help strike the deal that led to the Affordable Care Act. Today, he's Special Legislative Counsel at Alston and Bird's Legislation and Public Policy Group. We've given each of our panelists a charge, similar to the one for the last panel, and they were each going to speak for about 10 minutes, and then I get to play Jon Stewart or Bill O'Reilly or Bill Maher, whichever you decide, and then we will open it up for your questions. So, Senator Daschle, will you lead us off?
Well, I think the question is, what is the prospect for some resolution to the polarization that exists in healthcare policy debates over the last several years? And frankly, I'm a little more optimistic, and maybe not optimistic in the next 45 days, but optimistic more in the long term, because I think there is more of a consensus about where we are and where we need to go than most people get credit for. But before I get into that, let me just say how pleased I am to be on a panel with 3 such distinguished people and friends. Consider them friends, and I'm delighted to share the dais with them, and just thank Julie for all the fantastic reporting that she does on a regular basis. But I think there's a consensus about several things. There's a consensus about the fact that in the United States we have several institutional impediments that are going to have to be addressed if we're going to deal with this successfully. One of those impediments is that we don't really have a system in the United States. We never have had. We have a marketplace, and that marketplace is composed of a collage of subsystems, both public and private, that really don't interrelate all that well. And that collage is both a strength and a weakness. There's a market there that allows for competition, but there's also tremendous waste and inefficiency in the fact that it doesn't operate like a system. So that problem, that impediment, is a very serious one that I think on a bipartisan basis there's broad recognition we've got to address. How can we make it more efficient? And there's a second impediment, which is that we have a huge amount of lack of clarity, a lack of transparency across the board. I think I would argue that the health sector is the least transparent of any of the sectors within our economy. It's the only sector where at the time of purchase we don't know who's going to pay or what it's going to cost. And we don't have any real realization about the quality of the providers, about the costs provided in services, either through the hospital or the doctor. So the lack of transparency undermines one's ability to simply rely on the marketplace alone to accomplish a lot of what we have to address this series of challenges we face. I think there's also, surprisingly, a good deal of consensus around the 3 problems we face. We've got a cost problem, we've got an access problem, and we've got a quality problem. And I think there's also a fairly significant consensus about the degree to which we can all point to the problem or the causes of those problems. I already mentioned lack of transparency. I mentioned the fact that we don't have efficiency in this collage of subsystems. But I think there's also a great deal of consensus that we have far too much volume in our system, in large measure because of the fee-for-service, but the unnecessary care is driven in part by fee-for-service, in part by the fact that we have proprietary medicine where it's harder and harder to draw a line between a business and a practice in health. We have what I call market-driven medicine, where people see things on television that they like, they want, and tell their doctor they're going to get, and guess what? They get it. We have a significant degree of defensive medicine, and so all of those factors bring about the level of unnecessary care that some estimate could be in the $700 to $800 billion range this year. We have a lack of coordination, especially with chronic illness, and that lack of coordination and the fragmentation that has come as a result of that is something for which there is a significant degree of consensus. And then finally, I think people still appreciate how much fraud and abuse there is, both in the public and in the private sector, that has to be addressed. In fact, I believe there's so much consensus that you could even agree on what the goal is. Stated succinctly, I think the goal agreed to by Republicans and Democrats is simply this. We want to build a high-performance, high-value healthcare marketplace with greater access, better quality, and lower cost. And that is the challenge, I think, that all of us, regardless of party, regardless of philosophy, would agree to. But where I think the disagreement comes is what is the role of government in accomplishing that goal and in dealing with each one of those components of the problem that I've just outlined. And there, I think, we have the constant friction and the tension about public and private programs and public and private approaches to public policy. The one thing I think is fair to say is that this is all going to play out probably in three very specific levels. On one level, of course, you're going to see this play out most dramatically on Election Day, because Governor Romney and President Obama have very distinctly different opinions about the role of government as we address these challenges. So the single biggest and most consequential of all of the upcoming events affecting how this will all play out will be Election Day, when we decide who's going to be president and who's going to control the House and the Senate. But there are two others that I think are equally as important. One is the federal policy level that we're going to see really in two large components. One, policy in Congress, driven not really by changes in the authorization language. I think you're going to see it mainly on the budget side, and I want to come back to that in just a minute. But on the budget side in particular, you're going to see a significant degree of debate about Medicare and Medicaid, and the budgetary implications of health will be very much a part of the debate in the lame duck and thereafter. And I would simply say in that context that policymakers really only have two choices when they look at health budgets. As we look at ways with which to bring down costs, I don't think there's any doubt that in the past what we've relied on primarily to deal with the problems we have with regard to budget is a cut and shift approach. We simply have cut back on federal spending and shifted the costs onto stakeholders, onto beneficiaries, onto the states, onto business. I don't think we can do that anymore. The other option is to redesign and improve, and that's really what I hope we can find some consensus around. Can we redesign and improve not only the specific federal programs, but our global health approach, our global health marketplace, to address these causes that we know are driving costs today? The lack of transparency, the unnecessary care, the lack of coordination, the fraud and the abuse, the administrative costs, which we know are way too high. All of those have to be a part of this redesigning and improving if we're going to get this job done. So that's one. The policy area is probably the single biggest area where Republicans and Democrats are going to have to find the common ground necessary to move the ball forward. But the second one's going to be at the state level. And I think you're going to see a transformation of extraordinary scope and breadth and depth at the state level as we begin to address these issues. Much of what we're going to be doing is going to be in the states, with exchanges, with the new Medicaid expansion, with new marketplaces and pilots like the ACOs. And that too will generate a good deal of opportunity as well as complexity with regard to finding common ground. So, as I said at the beginning, I'm a little more optimistic than what the pundits would have us believe. We know we've got to do this. We agree on the goal. I think ultimately
we can resolve any of these challenges, and I look forward to talking about them this morning.
And I guess you must play the banjo. Governor England.
Well, thank you very much. And I'm delighted also to be here today and to have a chance. I was looking at the panel, and there's no question that I've got three people who know a lot more about healthcare than I do. They've been right in the arena. Now I've been on the receiving end as a governor for a number of years, so I've been there, and naturally at the Manufacturers Association and now at the BRT we have a lot of opinions, but we've got people who've been right inside working on the plumbing and what the big problem is. Billy will actually today, I think, step up and confess to substantial ownership of what we have, I suspect. But I'm delighted to come, and let me just start, because where I sit today at the round table, an organization of 210 CEOs, 100% of which provide insurance health benefits for their employees. So we're doing the right thing and have been for a long time. And in fact, the conversation, I wasn't at the round table, I was at the manufacturers when the Affordable Care Act debate was playing out, but the debate even at the manufacturers when it dealt with the larger companies was somewhat the same, that look, we hear what you're saying. If you like the health insurance you've got, you can keep it. And the kind of response back, yeah, we like it. We wish it didn't cost as much, but that's a pretty good deal. And we started out with, I think, a number of thoughts, and just what I want to try to do is talk a little bit about healthcare generally, talk a little bit about the Affordable Care Act, and then I think what Senator Daschle just raised is really important, because we're going to be dominated by budget and deficit discussions. And the key to that, the key to long-term fiscal stability for the nation, is what you do on entitlement reform, and specifically what you do on Medicare first, and maybe not far behind it, Medicaid. I think Social Security is somewhat easier than those two, or maybe significantly easier than those two. So you can't talk health care over a period of time without discussing those two big entitlement programs, and that necessarily, I think, brings us into a discussion of how then that healthcare system actually functions. I don't know how you can, it's not so easy just to say, well, we're going to reduce the money and we don't change the system, but you all can figure it out from there. I'm not sure it can quite be figured out. Yesterday we had about 92 of our CEOs in for a meeting, and a good part of the session was devoted to a conversation that Judd Gregg and Ed Rendell, who are co-chairing the Fix the Debt campaign now, which is sort of a public, I guess, phase for what I might roughly describe as Simpson Bowles plus, although Senator Daschle knows, I mean, they're trying to draw upon the work that Senator Menschel and Alice Rivlin did, and work that you and Senator Frist are discussing at the Bipartisan Policy Center. So there are a lot of forums around town where all this stuff gets talked about, but in talking with Senator Gregg and Governor Rendell, and how they want to approach this. I mean, they actually sort of waved off. I said, the question was posed to them, can you get entitlement reform sufficient to deal with the long-term fiscal condition of the country without substantively looking at how healthcare reform is carried out and how healthcare delivery systems work? And they basically took a pass on that and said, that's too hard. It may be very hard. I think that's what this conversation here today is about. I would say from a large employer standpoint, just to kind of to deal with those, as Senator Daschle, he's talking about cost, access, and quality. Those are actually three things we're pretty happy with. But obviously, a lot of our companies, we can look at their costs over recent years, they've been flat. I mean, they haven't really been going up. They've been managing extensively those costs. They're pretty happy with their quality. And obviously, there's access isn't an issue. I mean, this is employer-provided benefits that are substantial. The areas where they remain concerned about cost, obviously, are certainly as cost pressures are there, and where in some cases there are bargain contracts where they don't have cost controls that have been able to be built in, but it's been interesting. Even the UAW has had some bit of a transformation as they've now found themselves in charge of their own VIBA, and they're dealing with healthcare costs, and they've got this issue squarely in front of them. So the questions of certainly access to data, better data on cost itself, on quality, we think is a very important part. So we think there are technology solutions, and the Bipartisan Policy Center actually put together a group. There have been a lot of reports on this, and then of course recently there's been the reports of, well, you know, all this technology, we're not sure it paid off at all. But I think in healthcare and in education, they have very similar challenges. Actually, they're huge expenditures, they're big public challenges, and we don't have sufficient data on cost and quality in both those systems. And it's interesting, and they cannot be, unlike everything else that sort of is dealt with in the private sector, where I mean, Mike Duke from Walmart was sitting there yesterday, and he can tell in great detail every hour how much of what kind of product moves off a shelf, and is it moving in one region of the country versus another. I mean, we know in the private sector. I mean, Fred Smith wasn't there, but I mean, we can tell where a package is anywhere in the world at a given moment, and we can't connect up healthcare data so that a decision maker, a primary care physician, or a referral to a specialist doesn't have the records there. Come on, that's just not, and we can't do that over literally decades. That's just unacceptable, and that has to be done. And we can't actually measure performance of providers, and we can't tell what reinfection rates are in hospitals, and we can't find that only in a historical kind of sense as opposed to real time. That just has to be done, and that is again something that I don't believe there may be institutional challenges, but there aren't political questions. I mean, it's not a Republican or a Democrat perspective on this, and I think that's all part of how we get the kind of outcomes and how we get the transformation or the shift away from not what the spend is, but what are the outcomes, and how do we integrate into that then the kind of prevention that we need and the lifelong attention to healthcare. So these are things that I would say in the corporate sector there's a lot of concern. Obviously, I think at the same time, there's been an effort. A lot of the companies are self-insured. I mean, they've sort of had to deal with the competition that way, just bring it in-house. But I think there's a desire. Almost all of these companies have massive supplier base, and they worry about their supply chains, and so healthcare is very relevant and very important and very much of a concern. So I think from that standpoint, we've been joined in this debate. We're working very aggressively on all of the implementation of the Affordable Care Act. We think there are some potential strengths that can be used to improve, not only who's mandated to be covered, but also, and our goal is to see everybody covered, because again, if you're paying the bills yourself, the cost shifting that's taken place from the underfunding, under reimbursing, if you will, of a Medicaid system, or in some cases a Medicare system, I mean, that's often going to put pressure on that private market that we're paying the costs. But we would look at this and say, let's see what the exchanges look like. We're interested in that. Let's see what we'd like competition across state lines, of course. So we'd like to see this wide open. Let's really let it be a competitive marketplace. We think that, and obviously with the kind of transparency that I just mentioned on cost and on quality, we think there's a lot of micro regulation doesn't need to be in the law, and we push back against some of that. We're not clear why an agency, the federal government, needs to tell you how many pages you have to have as an explanation of your plan, and want that in paper in a certain type size, certain font size, versus letting everybody do that electronically and digitally the way we would do it in the 21st century if we really are an information economy, which we think we are. So the little retro pieces like that are, represent, I would just call them technical errors in the bill. Of course, that's what happens when a bill gets one House treatment. I mean, if Tozan had been actually in the House when this was being debated, he wouldn't have probably accepted it word for word coming from the Senate. Or if he had, it would have been the first time in his history that he would have done that. But this didn't get scrubbed. The errors didn't get corrected. They're there. I would say that, and I want to wrap this up, but as we look at the election, we think whichever candidate wins, there are issues in the health care law that have to be addressed, and the law has to be amended. You've got the president describing parts of it as unworkable. You've certainly got even more criticism coming from the Republican side of the aisle. The one thing I might certainly take a little different tack on from Senator Daschle's comments is that I haven't seen any data where more than 6 to 8% of the American people even list health care as an issue in the election. So I think it's very hard to say that the election's being fought over health care. There may be differences of approaches or opinions, but I don't think anybody's going to the polls saying, I'm going because of this. This is an economics election. It's about the economy. It's about jobs. And I just don't think that's going to be, it's going to be hard to read the election. I mean, we'll elect a president and people will, in all kinds of areas, say, well, this reaffirms my position on this or that, but it just doesn't look to me like that's there. But I do think the budget debate is there. But again, I don't think anybody's been specific enough on where they really want to go to give most people a clear idea on what the outcome is going to be. I just think there has to be, though, from a broader question of U.S. competitiveness and we're poised as a nation to have some pretty strong economic times if we can get our house in order, if we can make some of these decisions. We have to make them. We put them off too long. And I have very little optimism about the lame duck session, but I think most people, certainly in this town, but I would hope around the country, would recognize that 2013 is the time we got to stop putting this stuff off. We got to make some decisions, and they're going to have to be bipartisan. No matter what happens in the election, the Senate's going to be sitting there at 51, 52 either way. I mean, so you're still in a place where you're going to have to work together there, and we need to get at it. I look forward to getting into some of this discussion a little bit more later on. Thank you.
Well, I too am very proud to be here with this panel. It's a great panel, folks I've worked with. Governor Engler and I talking about high school kids out there in Arlington and McLean and other places. So we have a great rapport here with the panel that you've got. I want to thank Julie for all of what she does. She and I are both animal lovers, so we like to trade stories about our pets. And again, it's great to be here with Tom Daschle, who was an amazing individual to me when I first came to the United States Senate in helping me to acclimate. And now my colleague here at Alston and Byrd, Congressman Billy Tozan, our transvestocrat. Yeah. But a great friend to me, and he gets the last word. He always does. But so much that I agree with the other two speakers so far. I think the most important thing we see in this election is that America and America's voters find themselves near crisis situation in a lot of different places. We've talked about the budget. The budget's critical because jobs in the economy, I think, are the number one issue on people's minds. I think going to the polls, that's what it's going to be. It's what it's going to be about. Whether or not they've got a job, whether they're going to keep their job, whether they're going to be able to deal with the needs of their families in this economy. The budget deficit, just as Governor Engler said, we have ignored these things way too long. We've put them off and put them off and put them off in terms of fiscal restraints and our really lack of ability to compromise on solutions, and it's caused us a heartache at this point in terms of our economy. The cost of health care is got to be a part of that discussion, there's no doubt. When you talk about entitlement reform, and you talk about programs like Medicare and Medicaid, you look to what happened in the Supreme Court decision, and now you've got probably a pretty large donut hole in terms of states and the Medicaid coverage that was going to be a part of completing that expansion of coverage. And that's a question that's going to have to be answered both budgetarily but also by governors, and the questions that are going to be posed to them about how far are they going to expand that coverage, and are they willing to, what it's going to mean to them on state budgets as well, because the states are not in any better shape than we are as a nation, and that's going to be certainly a big issue. issue. But we are finding ourselves, as Governor England mentioned when he talks about private insurers or businesses that are privately insured, that insurance premiums are growing at the lowest rate that they have in over a decade. So I think the idea that we may be going in the right direction is starting to hit home. It's not perfect. Nothing ever is. I'm with Senator Daschle. I'm very optimistic about being able to find that consensus and come together. And it happens to be a crisis situation that we find ourselves in to bring that consensus, but nonetheless, that consensus of how we move forward on the economy and how we move forward on health care, which plays a big role in that, is something that I think can really happen. You cannot discount, though, I think, the unrest that is on the minds of the American voters as well about foreign affairs, and that has been an issue out there. So from all of that, from the budget, the deficits, the foreign affairs issues, and all of that, there is no doubt that health care in this election is not the top issue for voters. It was in 2010, and I can attest to that, but it is not in this election. I don't think the top issue. I think they're figuring out and wanting to know more about what health care is all about, and what the Affordable Care Act is about now and what it was about then. I think they realized that there was more in it that nobody really knew about, and people didn't want to take the time to understand. It's complicated. It's like farm programs. Nobody ever wanted to go on the Ag Committee because farm programs were complicated, and they didn't help a very large portion of your constituency. So health care is a complicated issue, and for most people over the past couple of years, they just really haven't had the stamina to try to dig deep down and find out, all of what's got to happen. I think what lies at a lot of the basis of it is the fact that for too long we have, as Americans, demanded instant gratification. And whether it's in the budget or whether it's in health care, we want to take a pill and we want to be better the next day. There's a lot more that is involved in health care and bringing down the cost and improving the quality. And there's much that's being done. Whether it's the Innovation Center or the innovation of individual practitioners. I went to a Harvard-sponsored event almost 10, 11 years ago. My husband went with me, met a doctor there who he traveled to New York to visit with, and learn about more better use of that data that you spoke about. And the data is there. There's some data out there. We just can't seem to compile it. We can't bring it to the point where we can actually utilize it. But there was a doctor up there in New York that was figuring out how to better manage a practice, and my husband was able to talk to him and figure out more of what would be applicable to the practice that he's in. So, there's got to be more of that, but we've got to start here in Washington getting along in a better way, finding those consensuses and working together. And there were many of us that did in healthcare. We wanted to find a consensus. It was just such a volatile and bitter arena, unfortunately. Olympia Snowe and I worked diligently together for 8 years on something that was a big component of the Affordable Care Act, which was the exchanges, working to find a delivery of health insurance that was very similar to what we had as members of Congress, and using those exchanges much like you have in the federal plans that's managed by the Office of Personnel Management, OPM. So there's some things in there that I think are working well, and things that we have found are not. It's not a perfect piece of legislation, nothing is. But I, for one, came to Washington actually a long time ago now, in 1992, quite naive, but having been a staffer, frustrated that our government was just a reactionary government, and Congress was reacting to crises instead of being proactive and trying to figure out how do we solve in a long-term way the problems that we faced. And hopefully I wasn't a part of the problem, but working towards being a part of the solution. And I think that that's a lot of what we're seeing now in terms of these crisis situations, is a move towards slowing ourselves down and realizing that we're not going to solve these problems overnight. They're going to have to be done over a period of time. And the Affordable Care Act is one of those that's over a 10-year period going to play a big role in that. It's on the right track, as I mentioned before, all the things that people are seeing now and enjoying. I've got several of my contemporaries whose kids are older than mine who are delighted to be able to keep their kids on their family health care plan until they're 26. You see good business models like the ESOPs and other areas that you mentioned somebody mentioned the UAW, but where they're seeing that engaging and vesting employees in the prospects of how they can lower those costs in healthcare and how that benefits the employee, their families, both in coverage as well as in cost and keeping businesses going. In short, the old system was broken. We can't go back to it. It's important for us to dig in and figure out the good parts of this bill, working in a consensus way to move those forward. The things that don't work or appear not to be able to work, and there's several that are there. Several of them that we said early on in the debate were not going to work, but that we can change and work together to make better. I think that's going to be important. I think the expansion of coverage is going to be a critical component of that, though, and we're going to have to figure out the best way to incentivize that. As the governor mentioned, you've got private businesses out there that are doing an incredible job of insuring individuals. We've got to keep those costs lower. But we definitely have to change a mindset. We've got to work towards more preventive care instead of the emergency care and the crisis-oriented approach that we've had for so long in this country. And so I hope that we'll see that. We'll see that mindset change in this election. After this election, well, I know we're going to talk about the politics of it and maybe what is going to happen. I think the Senate is still up for grabs. I think the House is going to probably remain Republican, but with a much slighter majority. And I think that just looking from polls that we've got here, that the president has a really good shot at staying in the White House. And I think that with that, it's going to give him a great opportunity to really be a bigger player in this healthcare debate in terms of solving the problem and not just getting something done in the sense of legislation. So panels like these are a good example, I think, of bipartisan conversation, people that have worked together in the past and who really do want to see the consensus building that needs to happen, and more importantly, the steps that need to be taken to move this country forward. So I'm proud to be a part of it. Thanks. We'll look forward to the questions.
Well, thank you very much. First of all, let me say that John Dingell, one of my greatest mentors and friends in the House in Michigan, the Dean of the House, 52 years of service, I think, once debated a colleague on an issue in the House floor, and he said that, I have the highest regard for every member of this House, but I have a minimum of high regard for the gentleman from such and such. There are people in the political world here in Washington with whom I share that view. I have a minimum of high regard for some people in this town, but I have the highest personal regard for the three colleagues sitting at this desk. I've worked with them and enjoyed them, and still work with them and enjoy the collegial relationship we have. In fact, my colleague from Arkansas, Blanche Lincoln, and I helped form the Blue Dog Democrats together. We were one of the co-founders of the organization. In fact, she's the only Blue Dogger who actually delivered a litter.
My claim to fame.
Beautiful pair of twins. So we go back a long way.
You got a litter too.
But let me tell you that healthcare is very personal with me.
Funny.
8.5 years ago, I was given less than 1% chance to live, to be alive today. I was diagnosed with cancer in the duodenum right against the pancreas, and required a Whipple surgery, Johns Hopkins, and a year of chemo and radiation at MD Anderson, where they gave me that awful diagnosis of less than 1% chance. I'm alive today because my doctor and my incredible wife and I were able to sit down in that little room at MD Anderson in Houston and make a critical decision. A bureaucrat didn't make it for me. No politician made it for us. No one stood in the way of our making that decision. It was a pretty important decision. It was a decision to use a new medicine that was not designed nor produced nor approved by the FDA for my condition. To take a chance on it. As the doctor told me, this medicine could kill you. I said, well, you just told me I'm going to die anyhow. What the hell, bring it on, you know? We tried it out, and it saved my life, pure and simple, when I was a goner. If I'd lived in Great Britain, I wouldn't have been able to have that medicine. The organization in Great Britain called NICE has ruled that it's not cost effective, so they won't make it available. So I'm going to draw a conclusion from that that'll sort of be a foundation for the rest of my comments. My conclusion is that it's extremely important in this country, where 50% of medicine is covered in some sort of government payer program and 50% is private, that we maintain that private side. And we give people a chance, like I had, to make a tough decision with my doctor to take a chance and use a medicine that indeed might not be available to other people in the world. It's that foundation that, with Tom Scully and Tom Daschle and others, and Blanche in the Senate, that we passed Part D to make sure that everybody in the country could have access to those kind of medicines. And we built it on a foundation of private competition among private plans, choice by seniors and what plans they wanted, but backed up by a subsidy arrangement with the government so that everyone would have access under that program, that no one would be denied a policy. No senior would not have access to the critical part of healthcare today, which is, I got a pocket full of pills that still keep me alive, that keep seniors like me and others alive every day. And we're very proud of that. Not only did that thing work, and seniors have this wide choice. I remember before my mother died, she's a 3-time cancer survivor, God bless her. She gave me bad genes for cancer, but she gave me incredible survival genes. Before she died, we switched her plan 3 or 4 times as we changed her medication needs. And she was able to get a plan that fitted her needs and was affordable under Medicare and under her conditions. We're proud of that. It's saving the government over $500 billion below CBO estimates. It's saving seniors $1,500 a year in their medical costs. So it's working, it's competitive, and seniors love it. About 94% approval on the plan. It's a good basis, I think, for building a foundation for settling some of the arguments we have over the ACA and what might happen. And I'll get to some of that maybe in Q&A a little later about what I think about some of those issues that my colleagues have already discussed in the healthcare arena. But this is entitled Healthcare and the 2012 Elections. I want to reverse that order and talk about the 2012 elections. Politics in Louisiana is a blood sport. It always has been. I mean, Earl Long, who was a brother to Huey Long, as you know, once said when he was governor, when I die, he said, if I die, he said, I want to be buried in South Louisiana so I can stay active in politics. We love politics. And if you ever had an example of bipartisanship, it's here. I have served in both parties. John Broad did call me a transvestocrat. And I'm writing a wonderful book you'll hopefully find in the airports one day called Memoirs of a Transvestocrat. Look forward to it. But I want to talk about the election for you first, because it will set the stage for what could or might not happen in terms of the next steps in healthcare reform and the ACA and what might happen to it. We are in a 50% age in politics. There is only one political structure that isn't subject to a 50% formula right now. That's the House. Almost everyone who's looking at the outcome expected in November will tell you that the House will probably stay Republican. You just heard that from Blanche. And I think most people agree that if there's any change in the House, it'll be within a 3 to 7, maybe even a 10-vote margin, but no more than that. Not certainly the 27 votes needed to shift the majority in the House. So let's start with that. The possibility of President, Senate, and House relationships with regard to the House is limited by the fact the House is not likely to change. John Boehner will remain Speaker, Nancy Pelosi will remain the minority leader in the House in all probability, and those two persons will be instrumental in the negotiations that will have to be constructed post-election on all of these major issues of tax reform and budget and sequestration and health care. The real outlooks only involve 4 possibilities. I took a little trouble to outline them for you today. I hope you can all see them. I'm going to describe them for you on this end. If you can't see, you've seen them. You've been looking at them, right? So let me turn it a little bit where all of you can see it. There are 4 possible outlooks when you eliminate the House changing, thank you so much, when you eliminate the House changing the leadership, is first of all, a status quo election. I've got it in the middle with a star on it because Blanche is right. Most pundits are predicting a status quo election. Most pundits today will tell you that it's likely to remain Senate Democrat, House Republican, and President Obama will be reelected. That's the consensus right now. Although I'll tell you, Charlie Cook, who's one of the best, says, this is his report, that a Romney win looks certain based on economic modeling. And an Obama win looks certain based on current polling data. Which means, Charlie Cook says, it's a 50-50 race. Bottom line is you got Colorado, Florida, New Hampshire, North Carolina, Ohio, Pennsylvania, Virginia, Wisconsin. You know, the rest of us are not very, very important right now, not even in Louisiana. Those are the states that are going to decide the presidential election, but and obviously the Senate. If you were to take a consensus vote among the pollsters I talk to every day, and most of us do, and most of them talk to you on one channel or another, the consensus is if the election were held today, the Senate, which is now 53 Democrat, 47 Republican, would be a 50 Republican Senate, a 50 Democrat Senate, which means that the Vice President of the United States, by consensus right now, if the Republicans do pick up the 3 seats they expect them to pick up, but not the 4 that would give them a majority. If that's the outcome, and remember, these are all polls and predictions, who knows? But if that's the outcome and that's the consensus today, then either Paul Ryan or Joe Biden would decide who runs the Senate, because whoever is the vice president under that circumstance, their party would organize the Senate, their leader would be majority leader, their committee chairs would be appointed from their party. And the whole outlook of the Congress would be affected by that one decision, who's our vice president. Because if it's Paul Ryan, you've got a completely Republican House and a possibility of a Democratic president. If it's Joe Biden, you still have what we have today, which is divided government. So let's look at the options. The option that is most considered probable is this one. Because if the president is reelected, obviously Joe Biden is in the Senate, and that's the extra vote needed to make a majority in the Senate. It's the most likely outcome. So the second possibility is a wave election. Now let me explain that to you. 2010 was a wave election. It was a wave election because it was driven by something in the electorate that changed dramatically. Most of our elections are decided by base politics. They were 50-50 in this country. Most people in America are just like me. They're 50-50. You know, so I'm all American here. The situation, however, changed in 2010, as it changes once in a while because of some event, something that happens that drives some base away from one party and over to the other. You know what happened in 2010? Well, no, in a sense it was Medicare. Let me go back to what happened. If you look at the congressional election right prior to the last presidential election, seniors over 65 split their votes evenly. 50% for Democrats, 50% for Republicans. If you look at the McCain-Obama election, McCain actually got an 8% advantage among seniors over 65. Seniors started to worry about what's going to happen in Medicare with this election, and the president's talking about a new big Medicare reform. Is that going to take money away from Medicare and what have you? 2010, Seniors got really upset because literally, as the Tea Party and others were agitating over the ACA, the case was made effectively for them that Medicare had suffered in the result. That money had been taken out of Medicare. At that time, we were talking about $500 billion, I think, and had been used to fund the ACA. That single fact, seniors were concerned about what was happening to Medicare under the new ACA, created a 21% advantage for Republicans in 2010. Not only did it create a huge advantage for Republicans, but seniors over 65 voted more heavily than ever before. You know, that's the one group you can count on the vote. And they voted more heavily. They went from 19% of the electorate to 23%. You multiply that out, that's a real 5% differential. So you take the Tea Party out of the equation, that 5% is what elected the Republican House. And changed a 60-vote Senate Democrat majority all the way down to this 53-member Senate majority today. A lot closer, a lot more difficult because of the 60-vote rule that Tom Daschle put into effect. You inherited it, as the President said. The bottom line is you could indeed have another wave election. Waves happen right before the election. They don't happen now. They happen in the 2 weeks before the election. That's how the Republicans won the House in '94 with the wave election. That's how they won the House in 2010. And Democrats similarly had wave elections where they were able to capture the House and the Senate at different times. If a wave election develops, it'll develop in the last few weeks. And if it develops, it'll develop because of one of 4 different reasons. One, it possibly develops because of the debates. You could have a great winner in the debates. Not likely, but you could. Secondly, you could have a surprise, an October surprise. And people say, well, what kind of surprise? Well, that's what a surprise is all about. Well, let's use our imagination. You got a little country called Iran with a guy named Ahmadinejad who believes in building a nuclear bomb and wants to bomb Israel, and Israel's not going to let that happen. And they don't care what the president says. If they feel like he's getting too close, they're going to launch an attack. You know that. We all know that. That's a big surprise. How does that affect the election? Don't know. It could. We just kind of had a mini surprise in Libya with this attack, and now we're debating, was this a terrorist attack, was it not? That's going to have some ripple effect on security issues in the campaign. There could be another surprise. You could have an implosion in Spain or Greece economically. All the best laid plans of mice and men could fall apart. And as Robert Burns said that wonderful poem, you know, all hell breaks loose. And you've lost your home and everything else. That could happen in Greece, and that could happen in certainly in Spain. They're still shaky, still trying to work it out. They've got plans, they're instigating those plans, but boy, best laid plans don't always work. We know that around this time. Thirdly, the third effect is economic news in this country. Now Blanche says, you know, she thinks things are getting on the right track. Americans don't believe that yet. And I think Bill Clinton said it best, the Democratic Convention. You know, it's not what's really happening out there, it's what Americans feel. That's why the Colorado study on economics predicts a Romney victory, because they're predicting it on the basis of economics in a given state. But that can change. You know, if economics do improve dramatically between now and November, that certainly bodes well for the president. If we get bad economic news in a series that last month, the last few weeks, they could elect in a wave election, Republicans under a scenario like this. It's so close, any one of these factors. And the last one again is seniors. I think the selection of Paul Ryan raises that possibility, because Paul Ryan effectively has begun at least making the case again to seniors to remind them of the problems they had in 2010 with the ACA. If they get excited about it again, they could again give Republicans a major advantage to offset some of the other major advantages the president has in many other categories of the electorate. So those are the 4 big, I think, questions that we have to look forward to that we don't know. There are 2 other possibilities. This one, I call them split 1 and split 2. It's where, in effect, the Senate goes Republican, and all of a sudden, the president is dealing with an all-Republican Congress. what does that imply? That implies a lot more gridlock and the possibility of more government by executive order. You saw the president use executive order on immigration. You saw him use executive order on the welfare bill we passed. He has said, if the Congress won't move, I'll move. He's threatened that he will use executive order. And he said publicly, I'll have more flexibility after the election. You know, that's often quoted statement he made with President Putin. So you can expect some of that. You expect some real clashes between the Congress and the president under this scenario over executive orders. But that could impact how the ACA is executed, how it's implemented. Split number 2 is where Romney is elected, but the split remains in the House and the Senate. And then Romney's got to deal with the divided government, the opposite of what Obama had to deal with. Now he's got to deal with the problems of a Democratic Senate. And how do you work with them across party lines? In that scenario, boy, I'd really watch a couple people, really watch Schumer, and I'd watch Durbin. Schumer in New York and Durbin are the 2 leaders right below Harry Reid, vying for succession leadership. And their politics is very different. Schumer, for all, very liberal, but very practical. Durbin, very liberal and much more oriented toward his ideology, less practical. Both good people, work with both of them in the House, but they're a little different in politics. I'd watch them both, because whoever has Harry's ear best in this scenario will make a big difference as to whether there's continued gridlock or there is cooperation across the aisle under that scenario. Well, anyhow, what does all that imply?
Oh, yeah.
That implies that John Engler's correct. They're going to kick the can down the road in this so-called lame duck. This is going to be the lamest duck I've ever seen. They can't, it's simple. Think of this with me. If there is a winner out there, if it isn't a status quo election, why would the losers want to make those big decisions? It's too damn hard. Wouldn't they want the winners to make? Wouldn't the winners want to make the big decisions early next year? So kicking the can down the road becomes very, very easy. I'll give you another good reason I think they're going to kick it down the road. You know how many Republicans have taken a pledge not to raise taxes? All of them. Most of them. Most of them. Yeah, that's right. But if the Bush tax cuts expire, and all of a sudden, middle-income Americans are faced with an 18% tax increase, and wealthier facing a 16%, because Bush actually lowered taxes more for the middle class than he did for the wealthy. That's not well known. But all of a sudden, if that happens, Congress will almost necessarily have to pass a tax reform bill that lowers taxes again. And all those Republicans that pledged not to raise taxes all of a sudden can vote for a tax decrease bill that doesn't quite decrease it as far as Bush did. And then there's revenue on the table to cut a deal on spending. Which also says, that makes good sense. Let's kick this stuff down the road and stuff like that. I've talked enough about the politics. Let me just make one other point and we'll open it up to Q&A. I know you all want to jump in here. If we have a 51 Republican Senate or a 50-50 with Paul Ryan as vice president, if we have one of those scenarios, keep in mind that the ACA was passed under reconciliation. Now, I don't expect you to understand the intricacies of that. So I'll try to simplify it. Most bills are passed in regular order and require 60 votes to proceed in the Senate under the filibuster rule. Reconciliation is a budgetary bill. If we had a budget, which we don't, you'd pass a reconciliation bill behind it to reconcile the various spending categories with the budget outline. So the reconciliation bill is limited to things that are affected by the budget, that the budget calls for. That is why when Scott Brown was elected in Massachusetts and there was no longer a 60-vote majority for the president, he backed into the reconciliation process to get the ACA done, because he could do it with 51 votes. If you could do it with 51 votes, the theory is you might could undo it with 51 votes. And that theory is bolstered by the fact that the Supreme Court, although it ruled that the mandate wasn't a tax in order to hear the case, ended up ruling that it was a tax to decide the case. And having decided it was a tax, it's a budget-related issue. So repealing the mandate, repealing the tax, if you will, is, by some legal accounts, what the Senate could do under a 51-vote scenario. Now, Tom's the expert on this, and I'll let him comment if he'd like to on whether those experts are right or not. But you can bet that McConnell is McConnell is the Senate leader, and Paul Ryan and President Romney are there. You can bet they will make an attempt to do repeals on the mandate as the first order of business in January. I said enough. I yield the floor.
And since I get the floor back, I will make that the first question, but I would point out that they didn't do the entire bill by reconciliation. They actually, people forget this, the House actually passed the Senate bill, reluctantly, but in fact the House passed the Senate bill. They did what was equivalent to the conference report by reconciliation. So everybody likes to talk about how, oh, well, they can repeal the whole bill by reconciliation since that's how they passed it, but they can actually only repeal half the bill by reconciliation.
No, that's not right. I don't think that's right. Maybe Tom can tell me. But the final bill, the final conference report is the bill, and it was done.
No, there were two signing ceremonies.
Actually, Julie is right, Billy.
In what respect? Explain that to us.
Well, because the bill was passed in two segments, and you have one segment that had nothing to do really with the ACA that was signed and passed by a majority, but reconciliation dealt largely with the differences between the House and Senate passed versions.
Yes.
That's all it did.
I got that, but was the tax, how that it's a tax, was it part of the reconciliation or the separate bill?
The revenue was part of the bill.
I mean, reconciliation.
Yeah.
No, part of the regular bill.
Part of the regular bill, right.
Ah.
Part of the Senate bill.
Well, you can see why we're going to have a legal dispute over this. Yeah. The mandate was in the.
You can do the reconciliation, turn the spigot off, and all the Medicaid expansions,
right.
all the exchanges,
all the entitlement,
all the spending, you can stop the reconciliation. The mandate, you probably can't. You can put some tax because it wasn't done. Technically, it's a tax, but it's not part of reconciliation.
Right. It was in the bill.
Or was it considered?
But pre-existing conditions, coverage to 26, all that stuff survives regardless, unless there's a bill passed.
60 votes. The subsidies, which is the bulk of it, Medicaid spending and exchange spending.
The question, though, and I think maybe the senator can comment on this too, is that if you don't have the underlying revenues, how do you enforce the mandate? And doesn't the bill kind of collapse around itself?
Well, I think the question is, if it's a President Romney, he's going to use his executive powers to do as much as possible to undermine the ACA. I mean, he'll probably come up with his own agenda, but a large part of it can be done with executive order. I mean, he'll have the authority, broad authority, because the ACA does designate a good deal of executive power to both the Secretary and the President. So it's probably, in some ways, a moot point, because I think, in essence, he'll be able to stop it. If it's Obama, he'll also have that executive power, and he'll be able to use that power to continue to allow this bill to evolve. So I think I'm still one who believes that legislatively, the only real effect you're going to see going forward, at least in the short term, even with reconciliation, is on the budget side. I mean, there's just a tremendous amount of entitlement reform and budgetary pressure that we're going to be having to address. But on the authorization side, I don't think you're going to see that much change.
Well, there's something that people are not, also perhaps not very aware of, and that is that there were, I think, 30-some-odd votes in the House on the ACA. And they have made at least, I think, 5 changes already that have been passed and signed into law. So that Congress, even with this horrible partisan split, has been able to make several minor but changes in the law under current Democrat-Republican leadership in the House and Senate. So I think, Senator, you're right. I think they're going to continue to do that. There will be legislative changes. The question, one of the questions I have, but maybe you can talk about it, is the IPAB, the independent panel that I know you supported and believe in, and I oppose, so we're on opposite sides on that one. But there is still a lot of controversy. It has not yet been implemented, a lot of controversy around it. What's the future of it?
Well, I support it just because I
You might want to
believe,
explain.
well, the IPAB, the Independent Payment Advisory Board, is this independent board that begins to establish a mechanism for making the tough decisions in health. I would say healthcare decisions, policy-wise, are the most politicized issues of any sector that I can think of. I mean, they're politicized for a lot of reasons, not just Republican-Democrat politicization, but you know, every savings is a loss to some sector holder and stakeholder. And so device manufacturers, hospitals, doctors, they all have their lobbying groups, and they do an extraordinary job of presenting their case. But at the end of the day, all of that pressure is brought to bear on Congress, and very little ever gets done. There's my Exhibit A is the sustainable growth rate. It's been an absolute disaster. Why? Because the sustainable growth rate is a totally politicized decision-making process today, and nobody can look at it objectively. I'd also ask, you know, if you left to the Congress the responsibility to raise and lower interest rates every year, to deal with the monetary policy, can you imagine what kind of a monetary policy we'd have? But we actually saw back at the turn of the last century that Congress didn't have the political will or the capacity to deal with monetary policy in a regular way. I would argue the same could be said for health policy. We just don't have the same capacity to make objective managerial decisions on a regular basis. And so it ends up politicized. We end up in this mired situation where nothing gets done. Having said that, because the IPAB is so politicized, nothing will get done on IPAB.
Sort of like doc fix and AMT.
Exactly, exactly.
Yeah.
Well, do you want to say something first?
Just a comment. The other side of the equation is that IPAB really takes away a lot of the jurisdiction, in effect, of the chairman of committees in the House and Senate. You hear a lot of grumbling among chairmen that this will take away their power to make health care decisions in both Medicare and Medicaid. As a result, it has some real controversial aspects within the two bodies, and the question is, will it survive politically because of that? Secondly, there's great concern. MedPAC currently is the organization that makes recommendations to Congress on issues dealing with Medicaid, Medicare, and those recommendations would certainly be handed over to IPAB. The difference is they're all recommendations. They're not mandates. IPAB would have the authority, if Congress didn't act within a certain amount of time, to implement its recommendations. Therefore, the mandate changes in the program. And the concern among policymakers, on the other hand, is because Medicare and Medicaid are so incredibly important to constituents in their district that they're deeply concerned that if those decisions are handed over to someone other than their own congressman, that they lose somewhat control over those decisions. That is in essence the real controversial nature of the IPAB.
Well, I would just say that's a good thing, but I would also say that you know, the legislation itself constrains IPAB dramatically in terms of what they can do. They can't affect quality. They can't affect overall benefit structure. I mean, they're so constrained that in a sense they've I think taken away a lot of the authority that IPAB would do. And then also, of course, it gives the Congress the right to override IPAB. So Congress, if it disagrees, can override. So it's, anyway, I agree with Billy on the likelihood that IPAB is going to get fully funded and fully appointed, at least in the short term, is not very high.
Yeah.
Governor England?
Yeah, I think this conversation is part of the argument as to why, as we think about where we go in the future, you'd argue that we create a system, or at least create an option in the system where there could be more decision making by the recipient of the care, and that's going to involve. I mean, there's the budget. As I said earlier, I don't think you can separate out completely. They're separate decisions, but they're so interrelated. You're going to have to do something on age eligibility, you're going to see that go up. I don't think there's any question about that. I also think you're going to see means testing, and that's going to be pretty significant. That won't by itself solve the long-term financial problems, but I think there's going to be more of that. I mean, you're probably not going to have an eligibility under a Medicare program for a Warren Buffett or Billy Tozin. I mean, you're going to start to draw that down a little bit. You're probably going to be making those kinds of changes. I think the other piece of this is that to the extent that people are allowed to manage their care, and we've seen some success. Billy was citing Part D success in terms of people being able to actually make decisions of who did the providing. I think that more flexible, more competitive kinds of arrangements that can evolve really add to our knowledge about how the system, could be driven toward away from just simply, sort of measuring, the volume and measuring the outcomes. And that to me is where we have to go. And I think that people will get there faster and accept it more readily if they make the call, rather than they feel somebody in an agency, whether that's in the state capital or the nation's capital, make the call for them. So I see that as part of this, and it's just hard to get there.
Yeah.
The other thing that's going to be on the table, I think, and this is I only raise it because it's in the room, is how long does tax deductibility treatment? I mean, we talk about the government outlay there.
Yeah.
I think that's going to get reviewed at some point, but to the extent that that's reviewed and there might be a different approach, that would have to buy something radically different and better. Otherwise, I think you couldn't come up against it. I think it'd be very, very hard. And I think, even groups like ours would say that's not something we want to have a conversation about unless we're really, really serious about substantial reform.
Could I direct a question at John and maybe Blanche that I think are very important? One represents the Business Roundtable, the other is a spokesman for the small business community, the NFIB. I increasingly hear from people in business that it might be much cheaper for them to pay the penalty for not insuring their employees than for insuring them, and that as a result you may see some real loss of employee coverage. Would either of you want to talk to us about that a bit?
Well, I don't think any of these pieces of the Affordable Care Act were meant to make it on their own, and the idea that their costs are going to go up hinges on whether or not we get the expanded coverage and we spend the time making sure that we're creating a not only better quality, more innovation, but a healthier workforce. And I think the lack of a healthier workforce is what's going to cause their cost to go up more than anything. But I think that without a doubt, regulations in terms of healthcare delivery are a big issue, and that's going to be a big issue in terms of the budgetary side of things when you start talking about all the implication or the implementation of the Affordable Care Act and what those costs are. But again, I go back to the expansion of coverage and how important that is. Already, you're finding that businesses can do more in terms of giving the decision-making process to the employee, whether it's lower premiums for better choices that employees make. I mean, those are great directions that we want to encourage them to go, and I think that helps bring their costs down. So I don't really see that happening, but I do think that the regulations are going to play a role in that.
Well, I mean, McKinsey did, I guess, what was the early study on this. There was a lot of angst about some of the data that they showed, but I think I think it's absolutely the case that when I was at the manufacturers, I mean, we had a lot of these smaller employers, and they absolutely, it's just easier to pay the penalty and, say, call your congressman, don't, and let them, it's cheaper, and not only easier in the sense that the SMEs don't have the benefits department. Mm-hmm. They don't have the contract with Aon Hewitt to come in and, figure this stuff out for them. And so I think it's, you throw up your hands. And the other thing, we worked hard in terms of working with the department on the definition of what's a part-time worker. Felt we made some headway there, but you got a lot of companies who are saying, well, wait a minute, where's that cut point, and could I restructure? You could have the inadvertent impact of having some people find hours trimmed in order to be under that part-time, under the part-time exclusion. There's everything is, it's like working with the tax code. I mean, everybody's got smart people looking at this and trying to figure out how they survive. But I think there will be people, and the fear would be down the road. We don't know much about the exchanges, and it was mentioned on the earlier panel. You've got some states haven't even acted at all. We don't know what the federal exchange as a substitute might look like. I think there's really a need. If I was trying to think about this far back in Michigan, if I was still the governor, you'd really be looking at how would you create some kind of a very flexible, transparent system where your Medicaid population and your exchange population, you could at least kind of run off the same platform and make a number of choices that would be a little different. I think, but I'm not there and I'm not doing that. I'm not sure how the Medicaid though is unsustainable, and I think even the idea, the question was raised again on the earlier panel. Well, will they fully fund it for those early years? I mean, that's just, everybody understands. I think at the state level, that's bait and switch. If they fund it for 3 years, the question is, what are they doing in year 6 on that? And I think that's and the dual eligibles that got some discussion also. I mean, for a long time, we had the position, and I don't know how this has changed. I've been gone quite a while, but I said, look, either you run it or let us run it. But we're really tired of trying to do this together because it doesn't work very well. I mean, we find you try to make the policy and us getting the bill, and we really don't like that. That's a state perspective of dual
Well, some of us
Billy,
wanted federal exchanges.
I'm sorry?
I said some of us wanted a federal exchange because...
Well, you're going to get one.
Well, no, I don't mean the state. I mean, some of us wanted a federal exchange in the legislation as opposed to state exchanges, because the proof is that for federal employees and the 8 million federal employees that are out there, a federal exchange works very well at giving you good quality care, what you need for your family or as a single person, and you get it at the best possible price because of the competition. I mean, the subsidies that
the federal employee chooses.
Exactly.
Which we thought was a good model for Medicare.
Well, I don't have a problem with making sure that, that they have more choice. Okay, we got to stop, I think.
Well, I would just say to Billy's question, if you look at Massachusetts, employer-based insurance has actually gone up since they passed
That's right.
Their bill. So, I mean, the only real anecdotal or real evidence we've got of what will happen, it happens in a state where we've seen employer-based insurance go up, coverage go up. So.
Okay, I think we have time for one audience question. Just one audience question. Sorry, these guys are you going to be the audience question? Okay. Have a microphone, Tom. At least use it. No, seriously, is there somebody who cannot leave here without asking a question?
No, I will.
Yes. Use the microphone.
Here's the mic.
I love Massachusetts. It's great. Massachusetts put 1 penny in their plan.
I tried.
100% funded by the Medicaid scheme. It's not a penny of Massachusetts money. It's not a penny of Massachusetts money in the Massachusetts plan, so it was very easy to leave your coverage.
Yeah.
But I have no problem with this for many years with the structure of President Obama's plan. There's a lot of the structure of President Bush 1's plan. The problem, which I think we discussed last night a little, which I think is going to blow people's minds, is adding 20 million new people to Medicaid on January 1st, 2014, and 17 million go through the exchanges. That's $200 million a year. So when you really get into this, I'm just curious of your response. Next summer, we're going to have a budget deal, and Republicans are not going to raise taxes, even if it is taxes go up and come back down. The other big moving piece is I don't think people understand the magnitude of the level of people coming to the system, which conceptually is correct. But this is 37 million new people coming on day one. $200 million of spending, that's a lot. It seems to be the obvious compromise next summer, which is where I'm looking, just asking for the middle. We discussed this last night. Republicans agree to raise revenue, which is probably not going to happen. Next exchange for the ACA implementation being slowed down and phased in, which is the way most bills like this are done. When we expanded Medicaid, done over 4 or 5 years, when we expanded others. This is a massive 1 year, flip the switch, 37 million new people in the system. It's incredibly expensive, and you got a $1.1 trillion budget deficit. It's pretty wild. When you get around the next summer, 2 little pieces that are out there that are politically viable, which another president might want to talk about, elected President Obama and the Republican these tasks. Raising revenues can be tough, probably going to happen. But when these guys really look around at the numbers, and now it's Republicans are 100% repeal and Democrats are 100% don't touch it, the middle ground is obviously slow this thing down and phase it in slowly. No one's talking about that. I'm just shocked.
Well, I think the only, as I mentioned last night, I think there would be a lot of interest in taking as pragmatic an approach to implementation as possible. And the only problem is that if you reopen the bill, you'd never get agreement among everybody in both the House and Senate that will only deal with the schedule for implementation. I mean, you're going to have people that are going to want to deal with the benefits package. You're going to have to deal with people with the exchanges, and the whole thing then becomes subject to yet another debate. And I don't think the Democrats, at least, would be very supportive of that. What they would be supportive of is giving the president greater flexibility, even than he has today, to slow it down or to be more pragmatic in terms of implementation. I already said, and I think it's fact that it's rare that a president and a secretary has the latitude and the flexibility that the ACA provides in this case. I mean, it's amazing, far more than we ever usually provide a president and a secretary. So they've got a lot already, but to get to your goal, giving them even more might be possible, but it would really have to be limited to that and that alone.
Well, I think we are officially out of time. We clearly have the makings of a grand bargain here. So, Senator Dash.
One more. Can I make one comment just to give you a dimension of what Tom pointed out to you? The state of Louisiana turned down the expansion. Governor General said, thanks, but no thanks, we can't afford it. The reason is, when they did the calculation, the Medicaid expansion in Louisiana would cover 49% of the state's population. Half of the people would have a Medicaid card. And after 3 or 4 years, they would have to pick up the cost in Louisiana for that expansion. And governors are facing that tough... 10%. Exactly. Oh, yeah, a big part of it. So governors are facing a very tough choice, because they do, obviously, they would like to take advantage of the federal support for expansion, because they do know they have people living under very bad circumstances without insurance. On the other hand, what does this commit the state to in the long run? And that's a big dilemma. And that's the sort of thing we ought to be working on.
Subsidy on the exchange, and that's even more than 47.
Yeah, I thought it was higher.
But you could also state by
the other
state.
going to have the income limits going to have to come down too. I mean, those were a mistake. They're too high, and they can't afford that.